the hole or clear that diameter of the vessel. Orbital has a spinning effect. It will, spin and cut it even deeper, and you will have a bigger lumen at the end of atherectomy. So, if you're doing a rotational atherectomy, many a times, if you're not using, it is not combined with an aspiration technique, it will have chances of distal embolization. But if you're using an orbital atherectomy, sort of disintegrates or pulverizes the atheroma into such small sized particles which are less than around 2 microns in diameter. And here, this is washed away in the stream and actually got by the reticuloendothelial system. And we can work with these devices from 4 to 6 French in diameter, so they require a very small diameter vessel. If you again compare lithotripsy with this, lithotripsy only breaks the calcium but does not modify the plug or does not cut the plug. But here you are cutting the plug as well as modifying the calcium, so it's a better device and it's a cheaper device. Now, if you look at this device, you have different types of crowns. So it's the same device for different crowns, which come from 1.25, 1.5 to 2 millimeter in diameter in a solid, classic, and micro configuration. And we use 1.5 for below knee vessels. We use 1.25 for below knee vessels, 1.5 for popliteal uh, and for superficial femoral arteries. And 2 for proximal part of superficial femoral arteries and for iliac arteries. This is a case for the lack of time because I just have to finish in time. This is a case for atherectomy. This is one of our first cases which we did. I think the first one in the country for peripheral orbital atherectomy. You have a long diffuse stenosis followed by a complete occlusion, which we had a subintimal wire, we passed the wire subintimally and then went back to the true lumen. And we did an orbital atherectomy, and you can see the result. This is orbital atherectomy with a coated balloon, but no stent. And so the results are pretty good and very predictable, and it is actually a very safe device to be used. Thank you very much.
So I have a question as an interventionalist. Do you reballoon behind this technology of erosion?
As a primary procedure, always. So we do an atherectomy, and then we do a balloon dilatation, and then follow it up either with a stent or a duct protector.
You put a balloon first to test the plaque or what?
No.
No.
We do an atherectomy, and then do a balloon dilatation, and then deliver the drug by the protector.
Second question, what is the system of aspiration if it exists?
So if you need an aspiration device, you only two devices, Jetstream and Rotorex has an aspiration part to it. These devices do not have an aspiration because they're just micro-pulverizing. Both rotablator and this orbital atherectomy will actually micro-pulverize. Pulverizes to a size less than 3 or 4 microns, and they are easily washed away. So they don't have an occlusive embolic potential. But if you are using rotational devices, and especially Jetstream and Rotorex, sometimes you have to use filter to prevent distal embolization.
I personally believe in such a technique because sometimes when you want to balloon a very difficult calcified lesion, sometimes the balloon breaks, as you know. So it could be useful. Comment, gentlemen? Comment? No comment? So you agree? You agree? No, it doesn't agree. What is the learning curve?
Actually, learning curve is not much. If somebody is doing peripheral procedures, this device is pretty simple. There's no sharp edges. You can pass it with just spinning, and it is cutting it. But the chances of restriction are very low. But anybody who is doing vascular intervention and suboptimal angioplasty, the learning curve will be done in just 3 4
somebody from the floor want to ask a question. Can you do?
So how do you decide which device to use? So there are so many devices. Different device on the basis of calcification. Because the basic drawback of all these devices are the wire has to be interlinked. That's what the basic drawback is. And when you cross peripheral long SSD regions, intrapocket regions, sometimes you don't know the wire is selectivity or interlinked. And if you use devices and the wire is subinterlinked, you'll have a. So the basic drawback of all the thread devices is that the wire has to go interlinked. This is one. And second is most of the devices are one-time use, and so they're putting blocks. The cost is so high. So I think as in all the interventionalists in the country, we should speak to the company. These devices are amazing. I've been using them for so many months now. But the limitation is so steep that you are not able to use because they all have a generator with it, so which they don't have enough generators in the country. The cost of each device is so high, and I think we all need to work together. And second is we need to teach people how to cross the wire interluminally because that's a very major drawback of all these devices is that wire has to go interluminally.
Dr. Kenya,
But
very short answer because we are 5 minutes late.
okay. So, talking about orbital, you may still go sub-internally, there's no problem. But yes, if you have a front cutting devices, you need to be, luminally and especially Rotarex and extreme. But in orbital atherectomy, like in this case I showed, I was subintimal. There is no problem because it's not a very traumatic device, and it is just cutting out the atheroma and also hitting at the medial calcification.
Thank you very much. This session is over. Thank you very much, Dr. Kenya. You were the only speaker. So we move on to the invited guest lecture session, and I call Ban, Bal, Saxena, Natesh, Kumudrai, Oda, Subrat Akuri, Shanshak Mishra, Ravul Jindal. And the first paper will be given by Kumud Rai from Delhi. Oh, nice to meet you, sir. On case discussion from Trump. You, you speak on thrombosis. Thank you very much, sir. You have 12 minutes, then 3 minutes of discussion. We must keep on time.
Thank you very much. Get this right going. Okay. So I thought we will have a few interactive cases. Most of them are reasonably simple. The first patient is 49-year-old male who presents a swelling of the right leg. There is some pain. He's obese, he's grossly obese, and diagnosed with DVT. The question here is, would the recommended dose be sufficient? And the second question is how long the initial therapy should last. And of course, there's no relation between these two because the second is important for other cases as well. We have all moved towards using DOACs as the primary modality of treatment. I guess some of us still use low molecular weight heparins for 5 to 7 days, but by and large, we can use, and this has been the guidelines of ESC, CHEST, and ASH, that you can use DOACs and they're non-inferior to the standard protocol of low molecular weight heparin and PKA. The agent is in use is dabigatran, edoxaban, apixaban, and rivaroxaban. And I was very pleasantly surprised to know that edoxaban is now available in India. There is a pharma company by name of Ventus which has introduced it, and I was surprised that there hasn't been much push from them because it seems to be a good drug, and we were part of the original edoxaban trial almost a decade ago. So we have Abigatran, we have Apixaban, and we have Rivaroxaban. Apixaban and Rivaroxaban are the common agents. You give Apixaban 10 milligram twice a day for the first 7 days, and then 5 milligram BD, and Rivaroxaban 15 milligram twice a day for 3 weeks, and then milligram both. These are the standard recommendations. The question is, does it work with obese and morbidly obese patients? And the answer seems to be yes. And the International Society of Thrombosis and Hemostasis in 2021 said that standard dose of rivaroxaban or apixaban are amongst are appropriate regardless of BMI and weight. And monitoring of these level of these drugs are not required. Uh,
Sir,
yeah.
can you come in the back? Can you come?
So I am not having a problem. Is there a way I can turn it without? Can I do this? Okay, great. Thank you very much. Uh, Next, we come to the second interactive case. This is a 39-year-old female, um, and her problem is heavy menstrual bleeding during the periods. She does not have any comorbidities. She was diagnosed with a DVT following 6 weeks immobilization because of ankle fracture, prescribed DOACs, and this is followed by heavy menstrual bleeding. Now, the patient concern is obviously the discomfort it causes her and interferes with her profession. And it also is of social concern, and she cannot be with her daughter. Now, we all know the length, the standard treatment has come down, especially for provoked PVT from 3 months, and sometimes we push it on to 6 months. But irrespective of that, and again, this is the same slide which I talked about earlier. So, what do we do? Whether we are giving extended anticoagulation or standard anticoagulation, and 3 months, I guess the patient can tolerate. But what about beyond that? This is a fairly common complication affecting women of childbearing age, and you can see here the incidence can be, or the prevalence can be as high as 54%. So it is a clinically relevant non-major bleeding for rivaroxaban, and these slides show that these are more or less similar with these two agents. With the dabigatran, also there is evidence to state that it is lesser compared to warfarin. And when we compare major bleeding in CRNM for apixaban versus enoxaparin stroke warfarin, again, the chances of a major bleeding or a CRNM is much lower. So what do we do in this situation? And the answer is fairly simple. And we used to do this with warfarin also 25, 30 years ago. If they are very sure about the dates, those of whom cycles are regular, you can have a quick rotation for those 2 or 3 days. That's the most practical thing, and this has been sort of validated in verbal communication as well by Dr. Thakkar, whom I had the privilege to meet in one of the meetings in London. So that should not be such a big issue, and it seems that it does not increase the chances of recurrent DVT if you give a short break for 3 or So coming to the duration of the anticoagulation, it depends on the risk-benefit ratio. When do you give anticoagulated, extended anticoagulation? Of course, clinician judgment is always there, but if it is unprovoked DVT or unprovoked VTE, we tend to give anticoagulation longer, and then the recommendation is that we should look for the thrombophilia profile, all the factors, whether uh, some, whether it's Atlas syndrome or whether it's protein CS deficiency, whether they exist, so that you can consider or recommend whether the patient should have a lifelong anticoagulation or not. If there are two episodes of unprovoked DVT, then clearly the patient should be on lifelong anticoagulation. So, it should reduce doses of apixaban be extended for unprovoked venous thromboembolism. And here is we all tend to follow the D dimers, and if the D dimers are high, we tend to continue anticoagulation, and as they turn negative, and so you realize over a period of time, the number of people which over 18 months follow-up has fallen from 732 to less than 300. So, recent evidence seems to suggest that D-dimer alone is not uh, accurate enough to decide whether you should discontinue your anticoagulation or not. And this is what the study indicated, that the cumulative events for recurrent DVT went high even in patients whose D-dimers were negative, i.e., they also could get recurrent DVT. Leading comparison between apixaban and rivaroxaban from the claims database, I think I will skip this. This is not a very robust evidence which we should be talking about in this forum. So the third interactive case is here is a patient who's got esophageal carcinoma, scheduled for resectional surgery followed by neoadjuvant chemotherapy and also possible other forms like immunotherapy. And VTE is a real concern. And we all know cancer is one of the biggest risk factors. Recurrent VTE is 3 times, major bleeding risk is twice, and death is threefold. Very often, VTE in a known patient of cancer can be the harbinger of a metastasis or widely spread disease. So ET is one of the major causes of death in these chemotherapy patients, and the question is, which type of anticoagulation did you choose for this patient, and whether renal function and weight, which we have already talked about. As long as the creatinine clearance is more than 30 mils per minute, you need not modify the dose. Some people even go down to 15 ml per minute, but less than that, obviously, you should not use these medicines. So when you compare these with dalteparin, and this is we select the study where the roxaban was compared with dalteparin, and you found and we find that the dalteparin had a slightly lower dose or risk of 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 bleeding as compared to rivaroxaban and Caravaggio, which is a very famous trial which I'm sure most of the audience would be aware of. In many ways a game changer. We found that apixaban had a very low rate, and it was comparable to that of. So there are many agents which cause recurrences, bleedings in these patients, which can cause VTE, and there is no effect of inhibitors or CYP3A4 or such agents which we sometimes tend to use in these cancer patients. So in the subgroup analysis with the anti-cancer drugs, whether it was hormonal therapy, biological therapy, polychemotherapy, and this is what you found. That when you compared apixaban to dalteparin, there were similar results. So what I'm trying to say is you could use these agents. both rivaroxaban and apixaban, perhaps apixaban may be slightly better in such a situation. So this is the end of my time, and I would end here. But this, most of these whether it's cancer chemotherapy weekly, it favors apixaban as compared to low molecular weight heparin. Kidney, I have already talked about the guidelines. We skip that, and that is the end of my presentation, sir.
We have
5 seconds.
we have question for you. Thank you very much. I have a very simple question before others, a little bit provocative. What you, what should you do for yourself?
What would I do for myself?
If you had to be treated, what would be your selection for yourself?
For my
For you.
that's a very difficult one. I
Tell
can,
us the truth.
I would, in last 5 years, use 15 years, actually, the last 5 years. I would do it. That's how I do the most. I'm very happy with it.
You advise to the audience this way of doing?
I would say, and we have come to a point, it may take some doing. If a patient has got a large VTE, maybe as Dr. Rahul talked about, a fairly large clot in the lungs, but the patient is asymptomatic, I tend to treat these patients at home, provided there is a caregiver, provided they understand the symptoms. I tell them 2 or 3 things. If you suddenly feel unwell, if you develop severe chest pain or breathlessness, just drop everything and rush to the hospital. And it really hasn't happened in any of my patients. So I tend to use more and more of DOACs and less of low molecular weight heparins even as initial therapy.
Sir, can you introduce yourself,
I'm Dr.
the
Amol.
name and the city and your position?
I'm from Jalgaon. I'm a cardiologist.
Cardiologist.
Yeah.
You have a question?
Yeah.
You go.
We encounter many unprovoked pulmonary embolisms from DVT. What would be the ideal time to go for a thermophilia profile, and whether we need to give some anticoagulation-free period before ordering antiphospholipid antibodies?
Absolutely, in general, and these tests are expensive, and I recommend that 6 months of therapy be given. The drugs be discontinued, ideally for at least a week before you test. If you are very nervous, what you could do is you could put them on low molecular weight heparin for 2 or 3 days. Give a week's break and do the thrombophobia profile.
Even in case of NOACs, we need to give it.
Yes, that is the recommendation. We should give at least a week's break. Rahul, would you like to comment on that?
Yeah, with the NOACs, 1 week. And if you're on other anticoagulations, at least 4 to 6 weeks. So, yeah.
Thank you.
Thank you very much, sir. Come back to the panel. Now my neighbor and a dear colleague will from Bangalore, Dr. Bell, speak of trials. The trials.
Thank you, sir. You are a very tough taskmaster, so I'll stick to the time. Fortunately, I have only not related topics, so I can stop anytime.
I give you 30 seconds more.
Extra for praising you. Thank you. Sir, I'll praise you once more to get one. Anyway, review what has been happening in the field of interventional cardiology in the last 1 year. Just go through the glimpse. It's interesting. So most important trial I think of the last 1 year has been the PREVENT trial. 1,600 patients, FFR negative. You would have left these patients for medical treatment, but what they did was they did the imaging and tried to find out if the plaques are vulnerable. Are they vulnerable to rupture? That they diagnosed by looking at the MLA, the plaque burden, the thin cap, and the lipid-rich plaque. And what happened was they randomized it to stent versus medical treatment. And they found that if you FFR negative, but vulnerable plaques, At 7 years, the primary endpoint of death, MITVR, is significantly less. So this trial, then another three trials are going on. If they become positive, we don't know how many times the coronary intervention will go up. And I believe and I hope these trials don't come positive, otherwise we will have a flood of patients having stents all over. For cardiogenic shock, we know the shock trial, IBP failed, CLS trial, ECMO failed. At last, we have a positive thing to latch on to, and that is the Impella. After this, 355 patients were followed for 6 months, randomized to Impella. They found that the primary outcome was significantly reduced by 26%. The safety endpoint, the vascular events were more, obviously, because of the large catheter, and now we have Impella with 9 French and 10 French. So these complications will go down. So if you have a patient of cardiogenic shock, you have evidence that you can use an Impella. Now, these are the two guideline changing trials. What they say that once, even in patients of ACS, you give DAPT, whether you are using aspirin and ticagrelor for 1 month, and then switch on to ticagrelor. Give the aspirin. If at the 1 year, there will be 55% reduction in bleeding, but there will be no change in MACE rate of death, stroke, MI. So similarly, the same thing was repeated in 4D ACS trial of prasugrel. What they did was give DAPT for 1 month, then they reduced the prasugrel to 5 milligram, took out the aspirin. Again, at the end of 12 months, they find a 77% reduction in the bleeding rate without affecting the MACE, that is death, stroke, and MI. So in the next guidelines, you will find that even in ACS patient, you need to give the DAPT only for 1 month, not the 12 months as was or 6 months, which was advocated on the present guidelines. These are two robust trials which are available. Now we know the partner trial. We started with very high risk patients for TAVI. We went into low patients, and now what they did was took out the patient who were really asymptomatic with severe AS. They had done the treadmill test to objectively prove that they are asymptomatic and subjected them to tower versus conservatively managing them. And they found that death, stroke, and hospitalization rate were 50% less if you do a tower early. But anyway, they found that at 3.8 years, 87% of patients will require tower. So we have come a whole spectrum. Now, if you have a patient of aortic stenosis and he satisfies the criteria, you can have a tower even in asymptomatic patients. We were talking of orbital atherectomy in peripheral vascular disease, but for coronary artery disease, they tested against the balloon angioplasty in the Eclipse trial, 2000 patient, a robust trial, and they found that the target vessel failure, that is the death, MI, and TVR, was not different. That means this trial was a negative trial. In this trial, the orbital atherectomy failed. So every device will not be successful unless it is tested. So unless you test these devices in a randomized trial, you should not be using it. If you look at the imaging also, imaging versus non-imaging group, also the results were not very different. Now, our patients, there is a risk of embolization. So most of the people were saying that you should put the cerebral protection devices, common device used is Sentinel, and then they again tested it whether the Sentinel is really effective. And this trial, they found it to be negative. So every patient who is undergoing a tower need not have a Sentinel protection, because if you look at the primary stroke rate, now, there were two previous trials, the COAP and the MITRA FR, which had a dichotomy of results. So everyone was waiting for the third trials to have in a patient of severe mitral regurgitation who were undergoing a mitral clipping. And they found that this is a positive trial. That means if you do a mitral clip in patient of severe mitral regurgitation, at the end of 2 years, the first hospitalization and cardiovascular death is reduced by 36%. So this settles the score in favor of MitraClip because the previous two trials were contradictory. Now coming to this trial, there is a patient of tower who have one-third of patients of coronary disease. So they compared tower and PCA versus SAVR, that is surgery versus bypass surgery. And in this trial, they found that if you do a TAVR versus plus PTCA instead of TAVR and CABG, in these patients, the patient protein point, that is death, bleeding, stroke, MI, and PVR, are significantly less in the TAVR group as compared to CABG in SAVR group. So that again establishes that the TAVR is there to stay. Now, in elderly patients, we are often reluctant to have these invasive procedures done, especially the patients who are more than 75 years. The severe RETA trial again just suggests that if you have a patient of ACS, you can safely undergo the technique of PTCA or stenting versus medical. So invasive treatment, even in elderly patients, is safe because the primary endpoint was not different whether you do medical treatment or invasive treatment, depending on the indications. Now, this is the first trial of ACS because there are many trials which have suggested in chronic coronary artery disease that if you do imaging, the results are better. But this is the first trial which they did the imaging in patients of acute coronary syndrome, that is 3,000 patients, studied for 1 year, and they found that a primary endpoint again of target vessel failure, that is death, MI, and TPR rates are less by 45%. So this trial establishes the role of imaging in patients of ACS. There are so many medicines which are given in a patient who is post-MI. These two trials, next two trials, we can take out two medicines. The first one is the colchicine, because the previous two trials had suggested the positive results, so they were included in the recommendations of the ACC guidelines. But this is the first trial which has shown, this is a large trial of 7,000 patients, showing that at 3 years there is no difference in death, MI, stroke, whether you give colchicine or medical. So this is the important trial, though it is a negative that you can take out at least one drug from the list of drugs you prescribe a patient of MI. And you routinely prescribe beta blocker. This is the second trial, reduce MI. Again, 5,000 patients. They said that routinely after post MI PTCA, if the ejection fraction is normal, you need not continue to give the beta blocker. You can stop it after 1 year. And you can. So these two drugs can be taken out from a list of therapeutic armamentarium which we write for patients of MI. Now, the next three trials are the upcoming technologies. If you have a patient who has nothing, you cannot not offer anything because he had multiple PTCAs, bypass surgeries, end stage of coronary disease, but also has angina. They reversely treated it. That means they produce the gradient at coronary sinus so that the subendocardial ischemia is relieved. They put a stent in the coronary sinus, which has a dumbbell shape, so produces the gradient, and they found that the ischemia and subendocardial region is reduced, angina is reduced, exercise time is reduced. The second trial is that the patients who are in heart failure, whether preserved or reduced ejection fraction, you create artificial ASD and put a stent so that this is maintained. Because basically you want to decompress the left ventricle, left atrium, because the pressures are high to the right side. And they found that in 500 patients at the end of 2 years, it was a negative trial, but they had a specified group. If you look at the divide them into preserved and reduced ejection fraction, you find that in reduced ejection fraction, creating a ASD will help there. So this is the future technology which we are looking into. We know the renal denervation. We have the RF. We have the ultrasound. Now the third way to do a renal denervation is by injecting the alcohol perivascular space in the renal artery. And this was also a positive trial. That means in the patients of hypertension, you can have a renal denervation. Now, after 1 year, we don't know what to do. Whether you do aspirin or clopidogrel. There was no trial, but many patients were not giving aspirin and using a clopidogrel. But now we have a 5,000 patients trial from Korea, follow-up of 3 years. Primary endpoint, if you use clopidogrel instead of aspirin, there is a 29% reduction in MACE rate without any increase in the bleeding. Now, two trials, large follow-up, in three trials, we know that the patient who have a coronary artery disease, if you treat them by guiding with the FFR instead of angio, you find and compare them with bypass surgery. At 5 years, the results, the PTCA is catching up with bypass surgery. We know when the syntax trial, the best trial, the freedom trial, the CABT was better than PPK. Here it is catching up if you use by FFR. Now, similarly, we have putting these towers in patients who are younger, who have low risk. So we have to have a long-term follow-up. I believe these tower walls will not last more than 10 years. So we have a 5-year follow-up with the partner 3 trial on the Sapien. Now, this is the 5-year result with the Evolute trial. These are the two most commonly used towers. So that means the results are holding up till 5 years. So every device is not safe. This is the last trial which shows that you should test the device before you use. All stents may be same, but all towers are not the same. This is the accurate ID trial of 1500 patients where they showed that the trial accurate neo tower was not non-inferior to the usual tower. So I think I've not taken your extra minutes. So we will have many more studies in 2026. I presented the fact. I'm sure if the time permits, every trial can be debated because everyone will interpret it differently, but facts will remain facts. Thank you.
Thank you very much for this good approach. And I have one question, uh, provocatively. So how much trust can we place in randomized study, or do we need higher authority to regulate them?
If I, how much,
You trust randomized study. You trust them.
yeah, not only random, but I believe that
Like,
yeah, not only random, but the randomized trial. I believe that every device should be tested against the sham procedure because we have seen in previous trials that when you did not do the sham procedure, sometimes the results were not that accurate. So there can be a placebo.
and do you need a higher authority, like ethical or technical, to regulate these randomized trials? Do we need somebody, an institution, or
There are
Right,
there is
absolutely.
there are
who
there is a India that TCPA
no, in the
regulates
world, in the world?
world. The FDA regulates these things for them. I think
I think
almost
the
CE
FDA is
regulates.
not involved.
Huh? Huh?
I think the FDA is involved. No, it's there's a sort of regulation because you just say that there are many, yeah, yes, yeah, yeah, but bias.
I
Tell,
think that's a very
tell me,
important point what you make. One is most of the trials are company-based trials, industry-based trials. What he's making is, and the results are definitely biased. I was involved in 2 or 3, and I could see uh, the how the physicians get molded. And I think what we definitely
I think
require.
this is a very sweeping statement, and every trial or every meeting is company sponsored. So
No,
this
not
company,
at all.
we are come to this
Yeah.
meeting, a company sponsored. That doesn't mean that what I speak, I will speak
No,
on
no, no.
behalf of
What
the
I'm saying.
company.
What point he is making is, we not every trial is false, and we also have to use a common
Having
judgment.
an authority may not be
Yeah,
practical.
yeah,
We go with the guidelines, and
yeah.
ultimately the best practice and the experience will prevail.
I totally disagree that you should go by
Sir, I have a
individual
very
experience.
sir, I have a small question. Are we going fast? We said APT for 1 year, now 3 months. Now we are almost going to 1 month. Are we going fast, or should we go focus on long-term studies?
See, problem in medicine is we should not go by intuition. My patient has improved by this technique or technology doesn't mean that it will stand in 100 patients. These people who have conducted the trial, they are statistically trial. All the trials which I have presented are from either in any case, or they
sir,
are not from
we
any
have a last question. Sir, who are you and where you come from?
I will just
Your
I have a
question,
question. Suppose
short answer.
Fox LED as a part of point two and whether to still try on the medical money. What is
long-term restitution concern, practically.
See, PTCA versus bypass surgery is a debate which I'm listening for last 10 years. There are only three trials which are available: syntax, the best, and the freedom. Three trials. Every discussion goes on that trial, and you can beat the data and get what you want. All those three trials suggested that bypass on long term will be better than PTCA, though cardiologists may not agree or agree. On the left hand, there are only two trials, Excel and Global, which are large randomized trials. You know, if you read the journals, how much criticized the Excel was. The surgeons disowned that trial, said that we don't follow these trials and they
We
give
have
us
to
another
we
so.
have to go on. Thank you very much. Thank you very much.
Thank you very much, sir. I think we call it's a wonderful
Back
talk.
and now, Mr. Introduce the next paper.
Yeah, I call upon Dr. Walid Kadro from Dubai. He is speaking on iliac perforation, prevention and management.
I didn't see him in the room. I know him from Dubai. Is he a Zoom? It's a Zoom,
He will be joining virtually.
not a Zoom. It's a remote.
Dr. Walid.
Good afternoon. This is Pietro. I'm a consultant intervention cardiologist with special interest in peripheral and endovascular intervention. Let me first thank the organizing committee for organized invitation. We thank Dr. Hanna for the continuous support, and this is my eighth consecutive year as a faculty for this nice conference. I'll be talking about the arteries perforation with concentration on prevention and management. So this is the worst complication that can happen to the interventional cardiologist or the interventionist. And the best way is try to avoid that. Don't let that happen to you by preventing that. And keep in mind the high risk lesion for perforation, CTO. And nowadays we are using large bore access for TAVR, EVAR, and Impella. Female gender is a risk factor for perforation. Tortuous vessel, oversized balloon, and high inflation pressure, stiff wires, especially the hydrophilic wires, and calcified arteries, especially at the aortoiliac bifurcation. And by using IVUS and IBL, we can really prevent perforation. IVUS will tell us the exact area and diameter of the calcification, and IBL really can modify the lesion and prevent the perforation. This is the registry disrupt peripheral artery disease study by using IBL. Just look at that. This is a registry with zero perforation, zero slow flow, and no dissection. So IBL really is a game changer, and I encourage everyone to use that for the peripheral intervention, especially for the calcified iliacs. Just keep in mind the new sizes, now 9, and 10, and 12 available, and try to familiarize yourself with the sheath compatibility. Here is written that the thing needs 8 French, but please take my word, the thing can move easily through the 7 French. Now, the use of copper stent is an important thing to prevent perforation, especially in the high-risk lesion. This is in the class C and D lesion, and the calcified severe calcification, and the CTO, and the area of the bifurcation. For the classic guidelines, they encourage the use of stent graft for the copper stent for severely calcified lesion at the vessels for which are hardest for rupture. Also, the SKY guidelines support this idea. So this is the SKY guidelines. You see a lot of the green, which mean class 1 indication for use for cover stent in this classified area. Try to familiarize yourself with the size of the balloon expandable cover stent, and keep in mind the 8L and 11L, and 11 needs 8 French, and this can be oversized by over dilation and can reach up to 16 millimeter. And those stents should be available in every cath lab who's doing an intervention. Also try to familiarize yourself with the self-expandable stent, self-expandable cover stent, and the Viran, and this is the list of that. All the other equipment which we may need in case of perforation should be available in your cath lab. This is the aortic occlusive balloon, all the sizes, the balloon expandable and self-expandable cover stent, coils, vascular plug. The large sheath is really a nice help in case of perforation of the external iliac artery that reduce the bleeding and give you some time to manage the situation. Extra support wire so hopeful in putting those complex stents. So there is a special kit that's called aorta emergency box that contain all of those things and should be ready for every complex iliac intervention. Let's discuss one of the cases. We call it perfection is the enemy of perfection is the enemy of good. This is 79 obese male with a lot of comorbidity and complex past medical history. He has severe peripheral artery disease with amputation and now wrist pain and poor healing. Also prepared for intervention. The CTA showed small abdominal aortic aneurysm, subtotal occlusion of the left external iliac artery, and included 10 bypass. And this is really large and static, and there were bilateral CTO. Let me show you the angiogram static vessel and the iliac area. This is the severe stenosis in the left external iliac artery. And, although it doesn't show here, but taking my word, it's really severely classified. This is the CTO, long SFA CTO, and the popliteal area, and this is the one below the knee. With all those comorbidities, surgery was not an option. And the plan was to proceed with endovascular intervention for that. And we decided just to treat the atrial, just let's treat the iliac artery and see how things improve. So we brought him to the cath lab to do iliac artery stenting, and the plan was what size of the stent with this static vessel. So we did the IVUS, and the IVUS showed that the diameter of the external iliac artery is 19 millimeter, and of the left common femoral artery 12 millimeter. So what's the plan? So in order to respect the size of the vessel, we decided to use 20 millimeter iliac nitinol stent, and this requires 9 French sheaths. So we did perform inflows, and we delivered the 9 French sheaths and exchanged to suprachoroidal wire and delivered the stent easily from the contralateral side. So we did this is the stent after the deployment, and we see the under expansion in this area, and we did post dilation with 12 millimeter balloon, and we said that's nice result. Unfortunately, I did not listen to my fellow, and they said please do IVUS again. So we did IVUS and still showed stent under expansion in this area. So we decided I decided to do post dilation, more post dilation with 14 millimeter balloon, and I did not stop at 4 atmosphere. I went to 8 atmosphere, and now with that, you see that there is perforation in the area, unfortunately. And I just quickly inflated the balloon to close the area, and this kit was available, and always ask for volume resuscitation, and ask for blood, and also important to call the surgeon and alert the staff and get everything available. So I put an 8-French venous access for volume support, and put the first cover stent, which is 8L by 93 millimeter. Just remember the diameter of the vessel is so large, and that did not stop the bleeding. We did post dilation, and did not stop the bleeding, still leaking. And so another post dilation up to 60 millimeters, still leaking. So this is, you see, still leaking here. So and I said let's put a longer stent. So this is a longer stent with more post dilation, but it's still blood pressure dropping, and we reached CPR. So now quickly I decided to stop the bleeding from above. So I put the aortic occlusive balloon, this is the aortic occlusive balloon in the aorta, and that's improve the blood pressure, and get an ultrasound guided access from the epsilateral side of the perforation. That's ultrasound in the left common femoral artery. And I put the 10 French sheaths, that's helped to seal the area. And we did angiogram from this sheath. There is no obvious leak, but whenever we deflate the balloon in the aorta, the patient dropped her blood pressure again. So we decided to put Gore limb stent, and it wasn't available in the cath lab, so we took her to the OR, and this is the angiogram after the put the Gore limb stent, and that was an important step to avoid bleeding from around the cover stent area in the because of the vessel. So we did learn a lot of lessons from that. This required more than 6 liters and a half of IV fluid, 6 units of blood, 1 unit of platelets, albumin, a lot of pressors, and the patient was discharged after 2 weeks. The lessons learned, really perfection is the enemy of good. We should have stopped at dilation with 12 millimeter or probably 14 millimeter. I did over relied on IHOS, but we should have accepted some malopposition and under expansion. We should have placed the aortic occlusion balloon much earlier, and since the iliac limbs grafts wasn't available in the cath lab, I wish it was available. We would have obviated the need for going to the OR. Another quick case, this 69-year-old female with a history of coronary heart disease and heart disease, and the found to have classified distal aortic coronary artery disease with SFA-CTO. This is the classification you see at the about bifurcation, and so those are high-risk cases, especially in a female patient. We did pre-dilation and then with 2 kissing cover stent. This is still deployed, and with post-dilation, and this is angiogram after full dilation, you see the perforation. Probably there are two areas of perforation, and the quick response, don't panic, re-inflate the balloon quickly to terminate the perforation, volume support, pressures, and yeah, add an additional large bore axis. Using a larger sheath can temporarily seal the area. Give specific order to your staff to get the blood bank ready and get the blood ready. Call the vascular surgeon, but don't reverse the anticoagulation. You should have this emergency kit available in the cath lab. Control the bleeding now from above, and probably by doing the aortic occlusive balloon, and probably you need to control also from the area and from below. And proceed as soon as possible for the cover stent and the reconstruction of the bifurcation area at the distal aorta. There is alternative modules to change the bifurcation, like Endologics, AFX the device, and other EVER device. Or you can put in covered stent to include one limb and send to the OR for fem bypass. Try to avoid covering the hypogastric artery if possible, because that may cause better claudication or bowel ischemia. Remember to use the set expandable Viaband stent in the external iliac, especially at the area of the common femoral artery, and always need to be oversized by 2 millimeters to accommodate the segment. So for this patient, you see the 2 area of perforation. We did 2 more cover stent, and after stent deployment, still you see there is some leaking around here. And with more post dilation, we get finally sealed the area. So this is another case. This is a 52-year-old female with risk education. She has a lot of risk factor, and the CTA confirmed that there is left common iliac artery and external iliac artery occlusion. This is the angiogram. You see this is the area of total occlusion. So we went from the contralateral side, use the front runner device to prove the total occlusion, and you see here the wire and the support catheter, and that support catheter has reached the hypogastric artery, and there were no luck either. We looped the glide wire in the external iliac artery, so we decided to go from the ipsilateral side by using ultrasound guidance from the lower part of the common femoral artery, and we went now retrograde, and this is the front runner went retrograde with some maneuver. We were able to go back to the true lumen here, and this is now we are true lumen in the aorta. So we did some pre-dilation, and then decided to put the balloon expander, the stent in at the common iliac, and then this is the angiogram after the stent, and we put the another stent in the external iliac, and after the angiogram, you see that there is perforation, and that's the perforation at the hypogastric area. So now, what's the decision? Some people think that we can put cover stent or vascular plug across the hypogastric artery, but this may cause, as I said, claudication and some colon ischemia, and probably won't prevent back bleeding from the transferic collaterals, and may lose the ability to control the bleeding, give us loose ability to control the bleeding at the source. So go directly to the OR is an option to suture the artery or coil embolization. Our patient was so stable, so we did some coil embolization, and this is the orthogonal view with a couple of coils, and this is the dilation of the stent putting, across the artery, and this is the angiogram final. We got nice result, and this is the cause in the hypogastric artery branch. So we got a nice result there. Quick case, another quick case. This is a 62-year-old female came for coronary angiogram, and the initial attempt from the cardiologist was from the right radial artery, but he failed because they were loop. So he attempted the blind stick in the left common femoral artery with multiple times, and no ultrasound guidance or fluoroscopic guidance. Probably he hit something and were not able to get it an access. So a help was called, and another interventional cardiologist came to assist, and he obtained ultrasound guided of the right common femoral artery with micropuncture kit, and he did the angiogram, the quick coronary intervention, but the patient started to complain of left groin pain and dropped her blood pressure. So we took a quick angiogram to the left iliac and common femoral artery, and you see here the extravasation and the tented bladder from the retroperitoneal hemorrhage. So now the patient is in shock. Shall we call the surgeon or react quickly? It's really important to react quickly and solve the problem within a few minutes, because if you exceed the 10 minutes, probably the patient will be dead. So we went quickly from the EPSI letter slide, put 7 French sheaths, and then delivered self-expandable Vyban stent 8x50 that sealed the operation, the perforation. And when you are putting self-expandable stent at this area, especially at the bifurcation of the femoral artery to the external and the profound, this is important to use some of the RAO and the LAO projection. You don't need, you don't want to put this stent across the bifurcation and cause a lot of ischemia. So we put the stent just before the bifurcation to the common femoral artery, and the patient discharged home the next day later. So just summary: most perforation are preventable. Try to do careful pre-op assessment with IRIS and use IBL. And always use 7 French sheaths. Being familiar with all the sizes of the cover stent, and consider the use cover stent primarily, especially in the high-risk lesion, even after IBL, and be prepared for the perforation with the kit, and train your staff for that. Remember, using an upsized piece at the area of the perforation may help you to seal the area temporarily and prevent and give you some time to solve the problem in case something hit the fan. So this is the summary, and thank you very much for your listening. I'll be happy to.
Well, thank you. We move on to the next presentation. Dr. Praveen Chandra will be presenting a non-femoral access for TAVR and large bore access for intervention. If you're joining through the Zoom, Dr. Praveen Chandra.
Yes. Thank you very much for giving me this opportunity, and I am sorry that I cannot join you there, but certainly I will try to do my best from here. So can you see my slides now?
Yeah.
Okay, good. So I'm going to present to you the difficult accesses which we are facing in TAVR cases and also in other cases where we need large bore accesses. So large bore access is something new for interventional cardiologists who are not doing peripheral interventions that much from the very beginning, but now a lot of cases are being done through transfemoral and also non-transfemoral access. So in TAVR, let us go to the TAVR because TAVR is the dominant, treatment now available for patients who are, needing aortic valve replacement above the age of 65, 70 years, high risk patients. But and the preferred access is transfemoral. But transfemoral is sometimes or many times not possible because either the arteries are very small, less than 5 millimeters, they are heavily calcified ring calcium, sometimes it is occluded or diseased aorta, severe tortuosity and calcification of transfemoral axis. So these are the situations where we have to start considering some kind of management for difficult transfemoral axis. So in this context, in our series, we have done non-transfemoral cases also, including transcaval, transsubclavian, and transcarotid axis. Then there are other indications of large bore accesses. Now this is a wide indication. So in patients where we use impella, so we need a 14 French axis, which also needs pre-closure treatment for these accesses, and then TVAR patients and also TAVR patients where it is an arterial large bore access. Now we are also doing a lot of venous transfemoral access or large bore access, where we do cases of MitraClip, PMVR, tricuspid valve replacement, pulmonary valve replacement, and micra pacemaker implantation. So there are some general principles which we have to keep in mind, and one is that what are the devices available? We have to know those devices for large bore accesses, and the devices which are available today are ProGlide, which is a stitch device, and AngioSteel, which is a plug, and also Manta, which is now available for large bore accesses. So these are the three kind of devices which we have to play around while we are going for large bore access, and one has to be kind of conversant and well experienced to use these devices in various ways and forms. Because sometimes we can use one ProGlide and one AngioSteel, or we use one ProGlide followed by another ProGlide. So all those combinations have to be understood properly. Now, the other general preventive strategies are that in large bore accesses, the most important thing is that we do a ultrasound guided puncture. So this is something which we have started practicing now, both for arterial and venous access. Because let me tell you, do not consider venous access as very simple thing, because we have had complications during venous access also when we were not doing ultrasound guided punctures earlier, and then accidentally if you go through a arterial access and enter into a venous access and do a big whole device, it can really lead to serious complications. Second is pre-CT assessment. Pre-CT assessment is also very important for those patients where you can do a pre-CT assessment, especially TAVR. We do in all cases. If you are in Impella, again, if it's possible, do a pre-CT assessment or angiogram to see what is the size of the artery, what is the calcification, what is the tortuosity. All these three things have to be assessed. And use of micropuncture needles is very important, because then you can even change your puncture while you have done. You can move to either up or down based on the micropuncture injections. And then post-procedural shoots are also very important from the contralateral side to basically see whether your puncture is fully treated or not, because leaving anything or bleeding will lead to serious complications, and this is one of the largest issues in large bore accesses. So here, as you can see that for TAVR, if the if the transfemoral access is not available, then we can either modify the arteries by doing IVL or sometimes just simple balloon dilatations, or we can resort to. Let me now tell you what our first step is to see whether IVL can work. The second step is we look for transsubclavian approach. If the transsubclavian approach is good, if the artery size is good, based on the CT, we decide for transsubclavian, or then comes the transcarotid approach, where we can actually access the carotid arteries through the help of our vascular surgeons, and then go from the carotid axis, generally the left carotid axis, and otherwise other axis is a transcaval axis. where we go from the femoral vein and then enter into the aorta directly from the IVC vein. So I will just quickly, take you through some examples of these accesses where we can really make a difference to the outcome. So in carotid access, generally it is left more than right, but right can also be done. And then the patient should not have any recent CTA, should not be having any disease in carotids, which is assessed both by CT and also by the Doppler. And then also, usually, mostly the carotids are bigger than more than 5, but sometimes they are small, so that has to be considered. And then, of course, the contralateral carotid should not have any significant disease. When then it is an open access, we have to know that the surgical colleagues have to open the access and give it to us. Transcaval access, when there is no arterial access, no subclavian, no carotid, no femoral, then we go from the IVC. Basically, here I'll just show you the example here, and then subclavian access in those patients where the transfemoral is not good and the subclavian is good. Mostly we go from the left side, open or percutaneous, and the subclavian should also be more than 5 millimeters for any TAVR procedure to be done. And it should be undiseased, and there should be no significant calcification. So these are the general guidelines based on which we decide which access we get. So let me show you one example here. Simple looking, TAVR here, everything was fine, but when we looked at the the peripheral arteries, we found that in this case where there was severe disease in the aortic valve, the patient had severe calcification of the femoral artery, and and we have to then decide whether the device which we are going to take will really cross it or not. What is the size of the device to be taken? And this is the formula which we use. And here is that in the normal femoral artery, in younger individuals, we can go 1:1, but in calcified femoral arteries, we cannot go beyond. And here is the case. You see that it is a iliac artery which is severely calcified. So there will be an issue, but here the size is good. But in some patients, if the calcification is on just eccentric and the size is good, you can still go through that and see other considerations.
Slides are not visible.
None of the slides are visible.
No, from the last slide.
Okay. Just a minute. Sorry. This is some problem. The last slide was not visible.
No, from the femoral side, just go on the play mode. That's it. Where the femoral artery size is visible.
Yes, sharing is gone. No. What happened? Yes. Okay, just a minute. Just a minute. I think there's some issue in the. I think there's some problem.
The IT guys, can they just have a look?
Just a minute. I think I'm just going through that because there was some. Yeah. No. Okay. Yeah, now I think I'm there. Do you see my screen?
Yes, we can see your screen. Just put it into the play mode.
Okay. Yeah, now better, right?
Yes, sir.
Okay, fine. So here you see that we are now discussing about the subclavian axis, and because here the patient had carotid blocking, the disease was in the femoral artery, which was very critical. So here we see that the subclavian is good. So all the assessments, pre-assessment is something which is very important, which we have to do through a CT angio, and this is something which is the key to success. And then once you have the access, and here you can see it was open access, but you can also do percutaneous access, and then the procedure remains as straightforward as possible. But sometimes if you see that the subclavian artery is not good, here the subclavian artery is so diseased, 4.4, and also we see that there is a calcification, at this, the origin of the subclavian artery. In this case, we start looking at the carotid, and you see that the carotid is very good. So if the carotid is good, that means it is a good access. So this, the surgeon will give us open access, as you can see. And this is very easy for them because our vascular surgeons have been doing carotid access and carotid endotracheal for ages. So for them, it is very simple. They just give us the access very quickly. And once the access is there, the sheath is inside, then it is again straightforward to do travel in the routine manner without any changes in the strategies. The only precaution is that the sheath, which is meant for the femoral artery, is long, so you have to keep the sheath out for a long distance outside the carotid artery. And then, as you can see here, we are doing this, self-expanding valve, which is going through the carotid axis, which is also having an inline sheath. So inline sheath also can be used, and here you can keep watching it on the screen, and once everything is in position, you can do it. So why do we do carotid access? Because it is very quick, it is fast surgical access, less dissection is required. It's a superficial artery, and it is a very kind of direct approach than the subclavian access. And these patients can also be done in back. Now, last thing is about the this transcaval access, and this is a young patient who had to undergo a TAVR for a bicuspid severe aortic stenosis, and you can see that this patient who was having Larsen syndrome had multiple skeletal surgeries, could not be taken for any surgery now, and here the access is very small. Arteries are very small, so we cannot go from any arterial side, be it femoral or subclavian or carotid. So here we chose to go transcaval approach. And here you have to enter from you can see that the subclavian is also very small. So this is the transcaval puncture from the aorta in the infrarenal portion. And all this is done through a CT planning for puncture site localization, and also knowing the aortic target site where we have to puncture. And the method is that we go from the femoral venous axis, and then we puncture here, take shoot, simultaneous shoot, we do puncture, IVC target site and the aortic target site are matched, and then we can do it. And once the puncture is done through this is a stato needle through which you go inside, and this is a snare which is in the aorta from the opposite side. We snare it and take it up into the thoracic aorta. And once we have puncture, you can see that the puncture is being done. And then once the puncture is done, the wire is in the aorta. We capture it with the snare, and then go through and do the proximal part of the aorta. And once the wire is inside, we can change it to the bigger sheet. And here is a big sheet, which is a 18 French sheet, which is taken inside. Once the access is achieved, then of course again the procedure is done simply. And in this case, we have to have 4 accesses: one from the left side, femoral artery, right side from the IVC, and also from both the carotid arteries, because the carotid also from the these the radial arteries from both sides, because we have to protect the coronaries also during the aortic valve intervention. And you can see that there is this protective stent which has been placed in the LED, and also the valve has been implanted, and you see that there is some narrowing of the at the left main ostium, so we put the stent there, and then once the stent is deployed, we take a shoe and everything is put, and then we take out the sheath and try to close it with the ADU septal occluder. In this case, there was some residual leak, so we completed it with a stent graft, which is from the left side, and we release the stent graft here, and without any residual leak, the patient is lifted, and you can see this is the final shoot. The covered stent, which is there in the aorta, no need to do any other things. IVC side doesn't need to be closed; it closes on its own, and that is how we are able to achieve good outcomes. So basically, non-transfemoral TAVR is indicated only in high-risk patients. So the first indication still is to do a transfemoral approach. And this is the algorithm which we follow based on the calcium, based on the size, and based on the tortuosity, whether we go from the femoral side or the non-femoral side. So, my friends, Carotid and subclavian access is safe, easy, and less invasive than transapical thyroid. So transapical is almost gone. CT scan assessment is vital in selecting the right axis, and we have to switch to the strategy before it is too late. So do not try to do it midway. Make a plan earlier and then go ahead with that. And trans-cable access, although appears difficult, but it is a very viable and very easy alternative with good results. But for all this, I think we need a good heart team, good vascular, surgical, and anesthesia support to do all these kind of cases. Thank you very much, and I will stop sharing my slides.
Thank you very much, Dr. Praveen Chandra. We will move on to the next talk as they are waiting. The next talk is by Dr. Bernardo Cortes from Cleveland Clinic, USA. He will be talking on DCB in coronary arena, an update of 2025. By Zoom, Dr. Bernardo Cortes.
Yeah. Hello, good morning, everybody. Actually, I don't work for Cleveland Clinic. I work in Cleveland for University Hospitals, just to puntualize. So let me share the screen. Thank you for the invitation. This year I couldn't make it, but I'm happy to be present virtually to update you on the most recent evidence about the usage of DCB in 2025. So please confirm that you see the screen so that I can start my talk.
Visible, sir. Go ahead.
All right. Yes. Thank you. So as I said, the last 12 months were quite exciting for a lot of novelties as pertains complex coronary disease management, specifically with drug-coated balloons. Starting from the REC-H1 trial, this is one of the largest randomized clinical trials on drug-coated balloons. This trial is comparing a drug-eluting stent to a paclitaxel-coated balloon, which actually is not with a C mark, so we don't have an experience with this device in Europe or in America. So that said, the idea here was to find, after 2 years of follow-up, the non-inferiority between drug-eluting stent and this specific paclitaxel-coated balloon. And actually, the non-inferiority was not met in these, I would say, simple lesion settings. So here the lesion settings were quite simple because lesions were short, severe classifications were not accepted, CTOs were not accepted, complex classification were not accepted. So in this simple lesion setting, this device did not reach the non-inferiority to drug-eluting stent, but it actually reached the non-inferiority in the small vessel disease setting. So in vessels up to 3 millimeters, the non-inferiority actually was by this device. And this is an important study which will be matched with the 2 other important trials that are on the go, and I will disclose about them later. The other big, I would say, huge novelty is that also drug-coated balloons in the end have now a ARC committee. So we have a DCB ARC project which came with the first publication in the European Heart Journal and in Neurointervention a couple of months ago. This project is a huge project led by Professor Patrick Sorayus, and this project actually started back 3 years ago, 2.5 years ago. We met many times, and in the end, we were able to gather the most important experts on this technology in the world, trying to understand with this first publication how a randomized clinical trial or any prospective registries with drug-coated balloons should be performed, and which are the characteristics, and how we should pursue evidence-based medicine also for this important part of coronary vascularization. Among the important information that we are having, so still discussing about small vessel disease management, is how important is the experience when we deal with drug-coated balloons. And you can see here from this slide clearly how from the first experiences that we had with Picoleto 1 was a trial performed in 2008 and 9 and published in 2010 at my institution. At that time, we didn't know how to use drug-coated balloons. So the pre-dilatation actually in drug-coated balloons was 24, 25%, and we implanted a lot of stents in the bailout fashion. But after that study, that initial experience, you can see here how the experience grows. So now we know that with any drug balloon, we have to predilate the lesion 100% of the cases. We have to decide according to angiographic data and selected cases to intravascular imaging data, which is the best tool that we need to use to predilate the lesion. And in the end, we have to keep bailout stenting as low as possible, allowing also for some not flow limiting dissection to the left. And this is a case that I would like to show with you. This case we performed a few years ago. This is a gentleman, 58-year-old gentleman with diffuse coronary artery disease in the left system with this double bifurcation. If you end up doing a complex stent here, the procedure will be very complex, very long, potentially creating risk and hampering with these big septal branches. So this is why we decided to try to pursue a DCB angioplasty here. So we started predilating semi-compliant balloon, scoring balloons in the ostial LED, and then we assessed the result of predilatation. This was the result, which was good. We have some not flow limiting dissection, type A, B, no more than that. And so this is the way to go. So now we have achieved the lesion preparation. Now we can deliver the drug, which is what we did with a blended therapy with some paclitaxel and some sirolimus balloon here. And this is the final result. You have to wait for a few minutes to take an orthogonal view, and then that's it. And this is the 3 months angiographic, and we brought the patient back to deal with this RCA CTO. We have more data, which recently came out. Picoleto 6 is a study that we presented at EuroPCR last year. Picoleto 6 is the first trial that is comparing several types of drug-coated balloons, sirolimus and paclitaxel, in terms of physiological performance. So this is a study on a small vessel. You can see here the reference vessel diameter is 2.2. Lesion length is quite long, it's 24 millimeters, which is much longer than the small randomized clinical trials in the small vessel disease setting, which compare drug-eluting stent to drug-coated balloons. And you can see here that paclitaxel actually, and this is not surprising, is winning in terms of geographic performance. The weight loss is negative. It's minus 0.02. It's negative. So we have a lumen gain. I have to say that in this study, in Picoleto 6, only experienced centers were invited to participate. Experienced centers with a good experience in using this in the novel regions. But sirolimus did a good performance. The rate of loss was 0.12. So paclitaxel did win this battle in terms of angiographic performance. But what we wanted to underline here was the physiological performance of these devices. And physiologically, you can see here that what was tested by NewFR, analyzed by Colab. Physiologically, the vessel NewFR during angiographic follow-up was very similar between paclitaxel and sirolimus balloons, 0.87 and 0.85. And also, the primary endpoint of the study, which is late functional loss. So it is like lateral loss, difference between the end and the angiographic follow-up in terms of physiology, in this case, was not dissimilar between paclitaxel and sirolimus. So the main information from the study is that paclitaxel is winning in terms of angiographic performance, but physiologically, sirolimus is not different. And an important other information that we got is which is the cutoff physiologically that we can accept at the end of a DCB PCI intake. This cutoff is 0.86, which means that for 0.86 and values above this level, the risk of ischemia during follow-up was very low. Whereas if you finish a PCI with DCB in de novo lesions and you have 0.86 or below in terms of FFR or angio-derived NewFR, then you have a higher risk of recurrences and ischemia. So in this case, you should consider to, again, come back in using other tools or in the end, put a stent in a bailout fashion. The other big important study that I want to discuss and that has been recently published in the European Journal is this patient-level meta-analysis called Andromeda. So I had the honor to coordinate this patient-level meta-analysis from three randomized clinical trials comparing drug-eluting stent and drug-coated balloons with one more trial, which is RESTORE in China, not on a patient level, but in the end, we were able to collect the data for 1,500 patients on 3-year clinical follow-up. So we have a long-term follow-up comparing drug-eluting stent and drug-coated balloons in this meta-analysis, which was done according to all of the PRISMA and Prospero methodologies. And the main message of this is that in a small vessel disease setting, paclitaxel-coated balloons, at least these types of paclitaxel-coated balloons that have been tested, are associated with lower incidence of MACE, 18.5% versus 24% with drug-eluting stent, 75% of the cases the later generation drug-eluting stent. So we have, in the end, 25% reduction of having MACE after 3 years in small vessel disease. And if we see the single determinants of MACE in this patient-level meta-analysis, we can see also that in PCB, we have lower MI, lower target lesion control, lower TDR. And importantly, in this forest plot, you can see here that the effect of paclitaxel-coated balloons here is better for the younger patients. If patients are 67-year-old or younger, they have a sustained effect and a better effect with paclitaxel-coated balloons compared to stents. Another small study is a meta-analysis on an important topic, which is the chronic total occlusion, TTOs. So we recently published this meta-analysis showing how there is no difference after 2 years in 2,000 patients between drug-eluting stents and drug-coated balloons in terms of clinical performance, TVF. This is an important information because drug-coated balloons are becoming a good alternative or a good hybrid therapy to CTO patients, avoiding the Chemin de fer or the long standing in this setting. The next step. So this year, we will be happy to present the data from the cardiac study from my foundation. The cardiac study is a study analyzing the performance of drug-coated balloons after any atherectomy or IVL with a sole DCB without any stent implantation. Core lab assessment of 120 patients. So this is an important study which would like to see the safety and the short-term efficacy of the balloons after atherectomy in highly severely calcific lesions. And the other big study that we want to present this year is the registry. It's called APVIC17, and this registry is analyzing the safety and efficacy of DCB in situ. So we were able to collect more than 750 patients treated for CTO with any type of drug-coated balloons, either paclitaxel or sirolimus, and we are going to present this data later this year. The other study that I would like to present you now, this study recently started enrolling patients, is PICOLATE-5. This is the other big setting where drug-coated balloons are being tested, and in PICOLATE-5, we are testing DCB versus a provisional stenting in bifurcation. So here we have not left main bifurcation, and we are randomizing patients to EBC-like, which is provisional stenting, versus full DCB with paclitaxel-coated balloon, 1 DCB in the main vessel, 1 in the stent branch, versus full sirolimus. So there will be 3 arms comparing these 3 strategies in non-left main bifurcation disease. And the 2 big trials that the first one will be presented this year at TCT are Solution de Novo trial, 3,300 patients in de novo lesions, where we are expecting the non-inferiority at 1 year between DCB and the sirolimus DCB and drug-eluting stent. And the other big trial is Transform 2. We recently, a couple of months ago, finished enrollment of this study, so hopefully we will be able to present this data next year, maybe at EuroPCR. This study is another randomized trial, comparing magic touch volumes for the balloon to drug-eluting stent in native S disease. That's it. I think this is my last slide. I want to emphasize the importance of the collaborators for reaching the goal of enrolling 1,831 patients in Transform. Thank you for your attention.
Thank you very much, sir. It was a wonderful talk. I think we'll move to the next topic, in situ fenestration for TAVR in aortic arch, and Dr. Ivo Petrov from Bulgaria will be joining on Zoom. Dr. Ivo Petrov.
Can you hear me?
Welcome, sir.
Hello.
Ivo, this is Jacques Busquet. How are you doing? We are very happy to see
Excellent.
you apparently
Thank you,
in a good shape. You have
Thank
an
you, Jacques.
important program. You go. You have 12 minutes.
It's my pleasure to speak at this very important conference. Hello, Jack. Hello, guys. Thank you very much, Dr. Kano, once again for your kind invitation of this very important meeting. Okay, Jack mentioned I will speak about different situations and different treatments in aortic dissection, especially involving the aortic arch. Not inspection to disclose regarding this topic. Aortic dissection is still quite a big challenge for treatment, and despite very well established guidelines and methods of treatment, in patients, for example, with malperfusion syndrome.
Sir, share screen, sir. We are not able to see the slides.
In fact, I
Go to the slide share.
now.
Coming. Let's wait. Yes, sir.
Excellent. Thank you so much. So,
Full screen.
yes.
Below, right side.
Is it good now?
Yes, sir.
Excellent. So nothing to disclose about this topic. I mentioned that the aortic dissection is a significant challenge, especially in patients with the so-called proximal treatment without touching the arch. In the proximal treatment, at least 30% of the patients will need to receive additional treatment because of the continuing growing of the false lumen, and this is in fact spoiling the results of the treatment. And because of the mortality, morbidity, and stroke incidence in reduced surgical procedures in the aortic arch is quite high. Probably because of that, the current guidelines are advocating endovascular stenting and endovascular procedure to be selected instead of surgery in case redo procedure is needed to be done. But what about endovascular? Endovascular in the aortic arch is also a challenge because everything that is put in the zone 0, 1, and 2 will require special techniques for cerebral vessels inflow provision because of the brain flow. So hybrid approach, the branching for carotid bypass. For me, these are also some kind of redo surgical procedure. Is not totally endovascular, so carries the risk of all the surgical approach. Speaking about fenestration and branch grafts, these are appearing very good options, but unfortunately, in most of the cases, they are not available sizes in acute and subacute cases, and unfortunately, they are very, very expensive and not always available on the shelf. Speaking about the totally endovascular options, in our experience, there are several. In fact, the one size bears the information like the need for motivation, covers the brachiocephalic vessels. Second is brachiocephalic vessels chimneys, assisted favor. And the third one, that I will speak more about is the so-called in situ fenestration of the already implanted arch endograft. So this is our experience during the time. I will show one case of a bare stent implantation that was published already just several years ago in a very young gentleman. Dramatic situation, totally compressed lumen, uncontrollable pain, and imminent stroke. So in this situation, we had to implant on emergency patient this bare stent that in fact centralize the flow from the coronary arteries to the renal arteries, and you see the evolution of the false lumen almost disappeared 1 year after the implantation of the stent. And this is not only the clinical, but imaging is really excellent 5 years after the implantation. Second option I mentioned is the brachiocephalic vessel kidneys assisted TEVA. So in this methodology has a very good experience and since long time applicable in the clinics. There are several meta-analyses showing really promising results. In our experience is also quite positive, and I'm showing here 57-year-old male, very complex, operated already for type aortic dissection with several syncope during systole of the arterial about 104. The reason for it is the huge compression of the lumen, not only on the level of the aorta, but also on the level of the brachiocephalic vessel. So in this situation, high surgical risk for recuperation, we decided to perform a kidney assisted with retrograde approach to the carotid artery, totally endovascular. You see there is no intubation. Totally endovascular from the retrograde carotid, retrograde right axillary artery, and parallel to the kidneys, we implanted the aortic graft with a very good result in this particular case. And this is also the imaging several years after. Speaking about the third option, the in situ penetration, the most modern, let's say, it's not a piece of cake to do this procedure because of exactly the preservation of the flow into the brain vessels after the implantation. There is a small meta-analysis of, in fact, summarizing the data from small surveys and particular cases, case reports. And to mention the majority of these publications are treating, addressing the puncture, the insufficiency of the left flavian artery. And only know that left flavian artery is not an issue. The biggest problem are the two carotids. And in this experience, we had in fact 13 patients during the last 1 year and a half. 5 with low penetration, 6 with 2, and 2 patients with all 3 brachiocephalic vessels penetrated with very good results. This is our protocol. In fact, the protocol is quite important. We are applying the so-called extracorporeal arterial bypass femoral carotid with the natural pressure gradient. With the utilization of the natural pressure gradient, we are using the femoral artery that is not used for the stent graft implantation to give the carotid artery connection with special tools. The aortic graft implantation of the rapid pacing in order to get implantation. And speaking about the penetration, the so-called electrified wire. So, three-coaxial system with the guiding catheter, microcatheter, and one more microcatheter with a very basic wire like the Asahi Stato and Asahi Conquest Pro with tip. We are connecting this wire to the electrocatheter. This is the flow you see, the flow femoral and up the, the natural femoral to carotid and superior artery bypass. And on the left side, you see the pressure that is measured to the carotid artery. So we are achieving 70% of the pressure from the femoral with this natural bypass of the femoral to the carotid. Here I'm showing cutting of the wire, and here I'm showing connection with the crocodile device to do electric cautery in order to make the penetration. Here I'm showing a 49-year-old male operated with dental procedure or with valve replacement and bypass for type A aortic dissection with big aortic regurg. Unfortunately, the house woman remained active and very huge compression of the woman, and because of that, definitely he needed a redo procedure. For a redo procedure, the Euroscore was non-acceptable, and because of that, we decided to make an in situ fenestration. You see the implantation of the valiant above the coronary arteries, and the three catheters already prepared. The right axillary catheter prepared to puncture the brachiocephalic vessel, the retrograde carotid, left carotid, common carotid, and the catheter from the LSA. So this is the impact in several projections. Rotational angiography is very important in order to aim into the stem graft, but not lateral, not to the organ, but the catheter to be aiming into the stem graft itself and to be perpendicular. And after getting this done and putting the lasso, the snare into the stem graft below the catheter, we are penetrating with the electrified wire. This is the moment of the penetration of the fabric of the valiant tibia. So this is the snaring of the wire in order to provide through and through maneuver. And over the through and through wire, we are making incremental balloon inflation of the fenestration in order to position the stent graft, the bridging graft. In our case, we are using the big graft. So after repeating 3 times this procedure, we implanted the bridging stents into the 3 fenestrations. And this is the final result with the gentleman with excellent result. Practically the false woman on the aortic level practically disappeared immediately after the procedure. And he has excellent clinical and imaging result. This case is more dramatic. 34-year-old female patient after car accident or trauma. I'm showing here the pelvic and hip reconstruction. Soon after the cervical approach of the hip and pelvis, a huge false aneurysm involving the left subclavian artery and not allowing a good landing zone for a stent graft preserving the carotid. And we have discussed with the surgical team for this young lady and the family, and also the patient, of course, and all we decided that there is a chance for totally endovascular repair. So this is the anatomical situation during the angio, starting the procedure using the catheters already positioned, the retrograde approach of the carotid artery, the position of the stent graft covering the left common carotid artery, the position in this case, in this particular case, after opening the mouth posterior, of course, under rapid pacing, we position the chimney from the left artery, and we make a fenestration. It's a combination of the two methodologies. We fenestrate the left subclavian artery. This is the penetration of the aggressive electrocautery connected wire, and this is the snaring of the wire. After the fenestration was opened, we positioned the stent grafts, and this is the final result, showing excellent resolution of the false aneurysm that almost totally disappeared immediately after the procedure with excellent result. And this is the final angio after the mounted closure device of the femoral approach. And this is the follow-up CT showing the very good practical full isolation of the false aneurysm. With that, I'm finishing. Despite endovascular advances in fenestrated and branch devices, thoracic endovascular aortic repair for ART pathology is a challenge. Parallel chain is mortal, and in-situ fenestration assisted total endovascular aortic repair is feasible. In-situ fenestration technique is evolving new strategy for complex high surgical risk patients with excellent peric procedure and midterm results in experienced aortic centers. And long-term results are awaited to precise the proper indication for the right patient in these very complex situations. And thank you very much for your time.
Thank you very much, Ivo. This is Jacques Busquet. It was a very interesting topic. And I would like to ask you just a technical question about the feasibility inside the cath lab. Do you use fusion with CT scan integrated to the cath lab, to the radiologic equipment, or do you use to reduce the contrast media, dioxide carbon
Yes,
dioxide?
these are very, very important questions. We are preparing very well the team and all the staff with the city in advance, and we are planning very thoroughly, like a rehearsal for the procedure itself. We don't have the fusion imaging option, and in fact, to use carbon dioxide on this level is practically not advisable. It's possible to be used below the renal arteries, but above the renal arteries is not a good idea. And I mentioned several times, in most of the cases, we don't use general anesthesia. We are making really endovascular approach with closure devices at the end of the procedure. And all this preparation is leading to very low and limited contrast utilization during the procedure itself. And you are absolutely right. And this is very important because these patients, in the majority, they have also kidney problem and some kidney failure. I believe that this technique, especially the fenestration, the fenestration has a good future. Many teams are working on a good way to make more predictable the penetration and the penetration itself in order to have a shorter procedure with lower risk for the brain perfusion. And this retrograde approach for brain perfusion is definitely working. We have, in fact, only one patient with a minor stroke, showing that the preservation of the flow into the brain is working.
Thank you very much, Ivo, for your technical expertise and your ability to speak in an international conference. Thank you very much.
Thank you so much.
And see you soon. Bye bye.
Thank you. We move on to the next session. Next topic, that is conduction system pacing. I welcome Dr. T.S. Clare. Conduction system pacing as an alternative to CRT. Very interesting topic.
Thank you very much. Thanks for Anna for the presentation. So this is a patient of 69 years female, and an angioplasty past section 25%. The left bundle one flat. This is the typical ECG where we would like to do CRT. So you see the angiogram, and if you see the angiogram here, the vein is not very encouraging. The patient of the vein will not give you good CRT. So what do you do in this patient? So what is the next step? The next step is that we did just the left bundle pacing. We didn't put any left ventricular lead in this patient. And look at the ECG. The LVAT was 58 milliseconds. QRS was 104 milliseconds. LVAT, for those people who do not know, LVAT means the duration from the spike to the peak of the R wave. This means most of the depolarization of the ventricle is measured by LVAT. So any LVAT which is below 70, 75 is very good for this. In this case, we got just left bundle pacing, no left ventricular lead at all, and we are very happy. And this is ECG after the left bundle pacing. You see here, this is a typical R prime in lead V1 and fantastic QRS. For the same patient, if you pace 5 millimeters, so So that means in this patient where there is anodal capture, so you are kept, the anode is kept in the right bundle, the cathode is kept in the left bundle, and you see absolutely a QRS, narrow QRS complex. Another patient had a bypass surgery, and this patient had a post pacemaker, and it was upgraded to CRTD in 2011, and ejection fraction was 35%, moderate MR. The QRS is 157 milliseconds, left bundle was blocked, not typical, but reasonably with IBCD. And this is the, the picture from the old CRTD was done. This patient was a non-responder. Then we added the left ventricular lead in this patient, left bundle pacing. The QRS became 115 milliseconds from CRT, which was 157 milliseconds. And he responded well. Ejection fraction brought to almost 40%, but parameters improved significantly. This is ECG of another patient. He had a traditional biventricular pacemaker, and if you see QRS is still broad. This is not the kind of ECG which we would like to see after CRT. In this patient also, we did added the left bundle lead, and if you see the QRS becomes much better, and patient improved significantly. So what is CSP and how does it achieve the CRT? The conduction system pacing means you want to capture the conduction system through the block. Most of these blocks are proximal, and if you see that the fibers run at in the spinal cord, for example, these fibers of the left bundle are on the left side from the beginning, fibers of the right bundle are on the right side. So if this is the block here, for example, can you see here my pointer?
Point here.
So you have a pointer here.
Right.
I don't know how to use pointer here. I go here. You know what is it being seen here? So this is, for example, this is the block here, and you put your lead below the block, and you capture the either distal hill or the left bundle. And if this slide shows you the traditional versus the left bundle pacing, the systolic blood pressure was much better if you pace the left bundle as compared to traditional CRT. And there are a lot of trials now. This is one of the trials where they compared the biventricular pacing with the CRT, and the result of this trial was that the intensity technique analysis, the LVF ejection fraction improvement at 6 months was much better with the left bundle optimized CRT as compared to traditional CRT. Uh, Another trial, November 22, the this trial also compared BIV versus left bundle area pacing. Left bundle area pacing achieved a larger reduction of QRS complex and larger DPTT and a clinical improvement in these patients. Uh, Now there's a new concept coming. It is not only the QRS width, it is the QRS area. For example, if you see on the baseline, QRS area is 330 microvolt, duration is 124. If you do this is QRS is 175 basic, and area is 331. IV pacing decrease the QRS to 124, area 79. But when you do the left bundle optimized CRT, your duration is 100 milliseconds. Fantastic. And QRS area is 38. So obviously, much more resynchronization by doing the left bundle pacing. So these are the same results. The QRS duration was the best with the left bundle area pacing, and the QRS area again was very significantly different from the traditional IV pacing in these patients. So there are so many trials which show actually that the QRS duration, new heart association, functional class, ejection fraction, improvement percentage of improvement in ejection fraction is much better with the left bundle pacing CRT versus the traditional CRT. Uh, another trial showed that improvement was better with the area pacing. So I don't want to go into the nitty-gritty of the trials, but the time is limited, and this is trial to show again freedom from death, better with the left bundle area pacing as compared to traditional YB, and this is freedom from death and heart failure. These are the all patients with typical left bundle or interventional conduction defect, and this is patient the typical left bundle. Both the categories showed much improvement with left facing as compared to traditional CRT. So there are multiple trials now. I think there is sufficient data to show this, and there is systemic review. There are registries. This is the concept. What you do is you paste the left bundle. If you get narrow QRS complex, actually there's no need of left bundle lead in these patients. But if you don't get the desired, if the QRS is still 120, 125, then these patients we put additional left ventricular lead. We synchronize between the conduction system facing, and that means you are taking advantage of both because some of these patients will have distal blocks. That is why the QRS you may capture the conduction system facing, but QRS may not become very good because there is a conduction, there are distant delays. For that, you have to put the left ventricular lead. So you resynchronize, you get better QRS complex in these patients. Another, there are so many trials to show, and radiologically, if you see RAO view, this is his bundle pacing, this is the left bundle pacing, almost about 1 centimeter below the his, distal his is the position where you get left bundle in these patients. Uh, Again, I think the same, a lot of data to discuss, but I'm not going to discuss because of lack of time. And look at this QRS duration. This is a traditional IB, this is a baseline, and this is the lot CRT. Lot CRT is the best QRS duration reduction. Similarly, the ejection fraction, systolic volume, and diastolic volume. So, few examples. It was a very interesting patient. I had done the CRT in this patient 2015, but he was a non-responder. So he came with LV lead failure. So that time we thought we will try conduction system. So we could achieve the distal haze in this patient, and the QRS became in this patient less than 100 milliseconds. And if you see here, even the HV interval, which was 82 milliseconds, it reduced to 44 milliseconds because we're facing distally in this patient. The block is proximal, and this patient improved very. Look at the ECG here. It looks like a normal ECG. You can't even differentiate that this patient had a left bundle. Before the distal bundle pacing, the QRS was 150 milliseconds. Now it was less than 100 milliseconds, and he improved very significantly with no time. Another example, patient came with heart failure, and after recovery, he came with complete heart block, and after a few hours he retained his normal rhythm in the left bundle, and we did the his bundle pacing, and ejection fraction from 25 improved to 45% in 3 months time. This was very interesting patient. He was a left bundle block, heart failure, 210 milliseconds. We want to do CRT, we just put the distal his in this patient and the defibrillation coil, and look at the ECG. On the left side is the pre-procedure 210, post is 104. I tell you that no traditional CRT can reduce QRS from 210 to 104, which is only possible with conduction system. So there are many of these examples which I can show, but I know that the people sitting on the dais will tell me that time is short, so try to do as. This was a very interesting patient actually. If somebody is interested in this patient, there was a patient IBCD and very wide 230 millisecond QRS, fragmented QRS. So we could get the capture of the left bundle, but even after that, the LVAT was 123 milliseconds. So we said, no, we need to do something more. And we put the additional left ventricular lead in this patient, and we got the LVAT up 70 milliseconds, and very significant from 230, we got 130 milliseconds QRS, which is, I think, very, very good. So, my dear friends, if I have to conclude, I think the conduction system pacing means it is his or left bundle. Nowadays, most of us have shifted to left bundle. Why? Because it is more reliable. The R waves are much better. In the distal his the R waves are shorter, particularly if your patient needs an ICD, then there may be a problem of sensing or even tachycardia, and it needs more skills. So most of us have to improve left bundle pacing, which is more reliable. R waves are good, and on follow we have seen that it stays the threshold as well as the R waves very good. So his bundle or left bundle pacing, you can achieve in 90% of the patient. It can correct left bundle. Not only left bundle, if your patient has the right bundle, that is perhaps the only way to improve these patients. It can be offered as a primary modality for CRT. If just doing the left bundle or the distal, you have narrow QRS sample, you don't have to do the left bundle. And I think there is a sufficient data to show now that left bundle based CRT is much better as compared to traditional CRT, and I think it will become the standard of the future. Thank you very much.
Thank you very much, Dr. Claire, sir. I just have a question. Is it, only using the left bundle, is it complete? Is there going to be some residual issues? Totally. Now we are using only the left bundle. Is it there going to be any residual issues?
No, no. Okay.
You're going to confirm
So the
that.
only thing is that when you do the left bundle linear pacing, for example, if the septum is scarred because of ischemic heart disease, or you have some kind of sarcoid or other septal disease, you may not be able to get the left bundle. Or sometimes you can have perforation, but even if perforation occurs, there will not be any pericardial effusion. So you come back and take a new spot.
Quickly, last question.
In this LV testing, when you do SM5, you can do a little bit more and it can go as you mentioned. So is it this bundle and LPB and left bundle, is there a difference in which one is more difficult in who have done it?
Distal heat is more difficult, need more patience because it's a fibrous structure. But left bundle there is a muscle, so it's easier to get. And we measure the impedance. How to screw it? You have you have a let's say 600 650 impedance, and in V1 you get W pattern. You give few more turns, impedance drops, and there will be time when you get the R prime and left bundle.
Thank you very much. I think we'll conclude this session.
Presume whatever myocardium is there at the time of CRT, everything is static and is going to be conducive. What is the chance of apoptosis and how does it alter the state of your
Chance of apoptosis.
Apoptosis. Well, I think we are doing the patient to improve the ejection fraction, to improve the contraction. I don't think they cause apoptosis at all in this patient. Most of the patients rather improve rather than. See, CRT doesn't cause apoptosis. CRT improve the ejection fraction. Apoptosis, cell death, will occur if there is additional either some inflammatory disease in myocardium or there is additional ischemic heart disease. For example, in ischemic heart disease, new myocardial infarction with a small branch, or in compare.
Well, madam, I think sir is available.
So I think we'll talk
because we are delayed. Sorry for that. So we conclude this session and move on to the
thank you
session. I thank Dr. Khanna on behalf of Chair, Dr. Vijay Bal, Dr. Jacques Basquet from France. Thank you very much, sir. It's wonderful to have you here.
This is not realistic. The expert panelists for this session are narration unit, which is the RP Larsen and the one go and in Parker and the client, Polish Pandey,
Well, I welcome Dr. Vishal Rastogi. He'll be presenting home time, a patient-centric measure in heart failure management. Dr. Vishal Rastogi.
I thank Dr. Anand Khanna for this invitation. The topic for today's discussion is home time. So we all know that heart failure is a disease has very high morbidity and mortality. Just a general thought, before I start, what do you think is the best metric to reflect patients' outcomes in heart failure? Is it mortality? Is it hospital admission? Or is it home time? So we have not heard about this home time till now, so it is very much evident. We all understand it. But what is home time? So mortality in heart failure is very, very high. We always are worried about cancers, but if you see the mortality of heart failure in men and women is more than most of the cancers, most of the common cancers. Only lung cancer has higher mortality than heart failure. When we talk about heart failure, it's a progressive disease. And the ACC/AHA first classified heart failure into stages A, B, C, and D, where the stage A heart failure means that patient does not have heart failure but has risk factors for heart failure. Patient may be hypertensive, diabetic, patient may have some other diseases which can lead to heart failure, but as of now, patient does not have any structural heart disease. The focus at this point of time is to mitigate these risk factors so that the patient does not develop overt heart failure. And this period can last from months to years, we don't know. When the patient goes into stage B heart failure, that means patient has suffered a myocardial infarction, or patient has developed valvular heart disease, but still the symptoms are not there, then this is known as stage B heart failure. And when the patient goes into stage B heart failure, the focus is that patient should not go into stage C heart failure, which is the symptomatic heart failure. But ultimately, a lot of these patients, after few months or years, will go into heart failure and they will have hospitalization or they will show up in the clinics with symptoms and features of heart failure. So here, the risk is highest because the patient is not on any protective treatment and patient is vulnerable to the disease complications. So then we start the treatment. This treatment will reduce the baseline risk. That means the patient will have better outcomes because now the patient is on guideline directed medical treatment, but this risk will never become zero. There will still be some residual risk. That's why we say heart failure is not a stable condition. Even in this period where the patient can live for months and years, but still continue to have risk factors and may have complications. This period, after this period of so-called stability, goes into worsening episode. So these patients will have hospitalizations, and once this happens, the course is really stormy because after that, the patient will improve with treatment, but will not come to baseline. So each hospitalization will set the baseline a little higher risk. And eventually, this will lead to advanced heart failure, where the patient is going to require advanced therapies like transplant or LVAD, or if the patient is not a candidate for these therapies, then palliative care only. So it is very important to mitigate this period of worsening heart failure or hospitalization, which will make patient very vulnerable to the problems of heart failure. That's why we are talking about this particular metric, which is home time, because this heart failure progression will really lead to ultimately death of the patient because the decomposition events which require IV therapy, which require hospitalization, they are really they lead to progressive deterioration of the myocardium. So while mortality and readmission rates have been widely studied in the context of heart failure outcomes, these clinical points to fully account for overall patient experience. What patient actually wants? Patient wants that he should live longer, but he should live healthy. He should be able to spend time with the family. Somebody is living for months together or years together in hospital, in the hospital, then this is not quality time. Patient is not interested in that. Home time is emerging patient-centered outcome, where it is defined as time spent with the patient alive and out of healthcare institution, out of hospice, out of hospital, in his home, living an active life with good quality of life. The patient should have good quality of life as well as minimum symptoms. It's an important patient-centric outcome for CV disease, and it better communicates the associated morbidity and mortality, including the burden of repeated hospitalization and time spent in rehab and nursing cares. So there are several factors which make this patient-centered home outcome measure highly relevant. So one important thing is that it accounts for total hospitalizations as well as the duration of each hospitalization. It accounts for morbidity as well as mortality, and also it's an objective measure that does not require any adjudication. If the patient is out of the hospital, patient is out of the hospital. It doesn't, and it is easy to interpret. So this success of these therapies, whatever we are giving, if we calculate home time and if these therapies are improving the home time, then these therapies are successful. And the interpretation could make comparisons among different trials more relevant, because sometimes we are talking about win ratio, sometimes we are talking about the p-values, different things, we are different metrics we are measuring. But if we just measure home time, then probably this is going to be the best measure. So this is underutilized clinical practice despite the important measure. This was seen in a study which was published in 2024, that in 30-day post-discharge period, 10% patients did not have any home time. That means they were immediately hospitalized. At 1 year, only 30% patients, that means one-third of the patients spent less than 50% of time at home, and only 22% patients had 100% home time. That means only one-fourth patients were totally at home, free of disease and free of symptoms. What happens if the patient gets hospitalized? So this period just after hospitalization is very vulnerable. We all know that after 3 months, the patient is very, very prone for re-hospitalization. Whenever there is a hospitalization, we stabilize the patient with therapy, and approximately 25% patients will be re-admitted within 30 days. Gradually, the patient will enter into the chronic heart failure, but during this 30-day period, the mortality can reach up to 10%. So first 3 months post-hospitalization are defined as vulnerable phase, because the patient is most prone for complications as well as rehospitalization. The clinical impact of prior hospitalization is very, very high, and it's been shown in India also that 30% of heart failure patients are admitted in 1 year, and 25% patients are readmitted more than once during 1 year follow-up period. So 1 out of 3 patients, that means 33% patients, are readmitted at least once in 1 year. What happens when patient is hospitalized? The mortality cumulatively keeps on increasing. In hospital, mortality is 10%, and it varies in different settings, but I'm just giving you a example where the mortality in hospital patients who are admitted with acute decompensated heart failure is 10%, but cumulative mortality after 30 days, 90 days, 1 year, 2 year, and 3 year goes up to as high as 50%. So what we need to do is prevent hospitalization. And how can we do that? We'll come to that in a while. What happens to those patients who are hospitalized? The quality of life goes. As I discussed earlier, the patient is interested in living good quality of life out of hospital with his family, with his friends. So survival also goes down, as I said, because the therapies which are being given, they are meant to improve survival, and they are meant to improve the hospitalization rate. So there are more the hospitalizations are there, the high mortality will be there, the quality of life is going to be poor because patient is mostly in and out of the clinic, and patient will have reduced home time. So heart failure therapies that reduce hospitalization, lower mortality, enhances quality of life, improves home time automatically. It's not rocket science. It is simple. Whatever therapies we have, if they are doing all these improvements, then the patient will be having more home time. So we all use guideline recommended treatment. Which treatment do you think is recommended for to improve home time? In fact, I would say all of them. ARNI, MRA, beta blocker, all have shown improvement in the patient's rehospitalization rate as well as mortality prevention. I'll just focus on the guidelines which say that ARNI is useful for heart failure with reduced ejection fraction patients, irrespective whether the patient is ACE inhibitor naive or patient has been given ACE inhibitor and is symptomatic. So this has been recommended both by ACC as well as ESC guidelines, that ARNI is now the first line drug for the treatment of heart failure with reduced ejection fraction. Indian consensus, which was published last year, also recommends early usage of ARNI, which means that ARNI should be started in all patients with ADHF before discharge, in all patients who come with de novo heart failure, as well as all those patients who have even, who are on ACE inhibitor, they should be shifted to ARNI because of the tremendous benefit it shows, which I'll highlight. So this evidence that there is evidence for sacubitril valsartan in improving home time, because the primary composite endpoint of in patients who were on ARNI as against enalapril, there was 20% improvement in the primary endpoint, 20% improvement in CV death, and 21% improvement in heart failure hospitalization. And this has been shown in the landmark paradigm HF trial, which was published as early as 2014. Also, in Indian patients, the data is there now, which shows that these same benefits are there in the Indian patients also, and Indian patients are similarly benefited when we use ARNI as against enalapril in our patients. So the survival benefits are same in Indian patients as well. So we should drive better home time through proven outcomes, sacubitril valsartan. And how do we do that? Because it reduces the risk of CV death and rehospitalization. And it's a recent trial which was published in 2019, which showed that 42% reduction in CV death and rehospitalization with sacubitril valsartan is compared to enalapril. Also, the rate of 60-day all-cause mortality as well as the rehospitalization reduced. The hospitalization could be because of either heart failure or it could be because of the any other cause also, and both were reduced by sacubitril valsartan, 32% heart failure hospitalization and 32% all cause admission. This is a famous slide by McMurray, which shows that sacubitril valsartan improves mortality over and above whatever ARNI was whatever enalapril was doing. So enalapril and ARB were the standard year earlier, and this 20% extra reduction over the ACE inhibitor therapy. We have not tested sacubitril valsartan against placebo because it's unethical to do so in today's era. But if you just add it, probably there will be 40% reduction in the total mortality if the patient is on sacubitril valsartan in patients with HFrEF. Also, the drug would improve the ejection fraction post-discharge in HFrEF patients, and being shown from a trial in China where the baseline year was 32%, and the patient was continued on ARNI. At 12 months, the ejection fraction reached 44%. So, in our clinical practice, also multiple patients who have been kept in transplant list, who have been advised CRT and ICD therapies, they no longer remain a candidate for these because now the ejection fraction has improved and patient is symptomatically better. The longer the patient is on ARNI therapy, the ejection fraction improvement is there, and it reaches significant p-values as well in this trial. Not only the ejection fraction, but all the markers of the LV indices, which means the end diastolic volume got reduced, the end systolic volume got reduced, the LA volume reduced, as well as the E by E prime ratio improved. So that means the congestion improved as well as the LV functions improved, and all the indices also improved when the patient was started on ARNI. The other important aspect is quality of life and functional capacity. So the KCCQ score, peak VO2 max, 600 walk distance, respiratory efficacy, domestic activities, sexual activities, all these activities improved when the patient was on ARNI. And it's been shown that the significant change in score differences with sacubitril valsartan compared to original analysis at 8 months. You can see that original analysis is shown in the yellow, while the sensitivity analysis at 8 months is shown in the dark brown, where you can see that all the day-to-day activities like dressing, showering, climbing a flight of stairs, walking, visiting family, all these indices improved over a period of 8 months in those patients who were on ARNI. So that means patient is having good quality of life if the patient is on ARNI. So this improvement is not sustained. It is not just a long-term period, but also it occurs pretty early. And it was shown that the benefit, the cases improved within first 2 weeks after starting ARNI. And we have seen this in our clinical practice. As soon as we start the drug, patient continues to improve, and they would say that they are feeling much better on their next visit itself. The KCCQ improvement was more as compared to the ACE inhibitors in HFrEF patients. 4.5 points improvement was there in the than the KCCQ score in these patients who are on army. So, given in the hence, the home time is defined as the time spent by the patient alive and out of any healthcare institution. It represents a novel trial endpoint that intrinsically reflects mortality and hospitalization events, but with a patient-centered approach, because patient is more concerned about good quality time, free of disease, free of illness, and out of the hospital. Heart failure therapy that reduces hospitalization, lowers mortality, and enhances quality of life, improves time for heart failure patients. And sacubitril valsartan is a guideline recommended first-line treatment for all HFpEF patients, irrespective of their NYHA class. Sacubitril valsartan has proven benefits which maximize home time in HFpEF patients. Why? Because it lowers incidence of composite PV endpoint, which means death as well as the hospitalization. It improves quality of life, and it actually improves the echocardiographic parameters of ejection fraction. Thank you.
Thank you, Dr. Vishal. It was a very good, comprehensive presentation. I just have a small question. What's your experience with home time?
My experience with hometown means what happens to
What
these
happens
patients
to patients?
on
You
heart
have
failure
a
therapy.
series of heart failure patients, and
So, the problem with heart failure is that, and I see pretty advanced heart failure patients because I run an advanced heart failure program where we have transplant and LVADs also. So, unfortunately, these patients are labeled as frequent flyers, which means that they end up spending more time in the hospital than they are at home when they are reaching more advanced stages. So the quality of life really, really is bad for these patients. And even if they are at home, they are mostly dependent on their relatives, on their caregivers to take care of their daily needs. And once we are giving these patients these guideline-directed medical treatment, which include ARNI, which include SGLT2 inhibitors, which include MRAs, which include beta blockers, a lot of these patients, they come back to a meaningful life. And it also, it is also should be emphasized that simultaneous cardiac rehab program is also very, very important, because unless we make these patients do symptom-limited exercise and gradually build up their muscles, build up their nutrition, they are not going to improve. So it's a comprehensive care which is required to improve home time in these patients. That's why the concept of home time is great, because it encompasses the entire therapies in the sphere of health.
Yes, just a small comment that when we discuss these patients, these number of drugs which we are using today, of course, they may be beneficial, but in Indian patients, especially with reduced ejection fraction, they already have a very low BP and they continue to take these medicines, they'll end up with very low BP like 90, 80. And this home time become bedtime. They are just sticking to the bed. They're not able to get up. And when I get a phone call from such type patients, then I tell them stop all medicine immediately. They become all right. They are able to get up from bed. We must teach them home monitoring of blood pressure and signs of dehydration. If they are losing a lot of water and electrolytes, then you should tell them to stop medicine again. Start.
from my side is only one point. Many of the patients, since we are starting all the four pillars of the drug, even the ejection fraction is not improving. The quality of life is definitely, yes, it's improving. So I don't know how and why this quality of life is improving. Like patient is usually doing all these drugs. Ejection fraction 30%, but he's going off it and doing well.
Very good observation. Yes. So this is very commonly seen, though, the mechanistic studies show that there is some improvement in ejection fraction. But ejection fraction, as you are aware yourself, you have been, in these patients, that ejection fraction is a very, variable metric, and somebody who's doing ejection fraction will measure 30%, somebody will say 35%, somebody will say 25%. So as a number, as a heart failure specialist, I stop seeing the ejection fraction number after a while. I just go by their NYHA classes, and the more I see is probably their right ventricular function, because once the that goes south, then the patient will not remain a candidate for most of the therapy. So I would say that the ejection fraction as a number we don't follow.
It's subjective thing. Thank you.
Sorry. Yeah, definitely. So there are multiple parameters which are more sensitive, which have better prediction.
Well, thank you very much. It was a wonderful session, Dr.
Time and very informative. This is new for us. Time.
We have to calculate in 1 year how many days they are staying. Nice presentation.
On behalf of all the chairpersons, we thank Dr. N. Khanna and we move on to the next session.
Good evening, friends. Uh, Obesity is a man-made disease. God made us and we made the obesity. Believe me or not, it's changing over the last 4 decades. I drove bicycle up to until I finished my DM cardiology. Show me a single boy today doing MBBS who drives bicycle. There is a municipal corporation school in front of my house, and watch those guys, lower middle-aged children coming out of the school. One hand lays, one hand coke. So, obesity is clearly a man-made disease, and I remember my father used to push me out on Sundays. Sunday पढ़ने के लिए नहीं होता है. Sunday is for playing. Show me one single parent today who is doing that. So, just to put in the context, of course, now we have obesity and obesity experts or surgeons who will be starting the session.
Okay, thank you. I'm actually very glad that this session is part of the cardiology meeting because obesity, we all know, is mother of diseases, and cardiac disease is something which is one of the byproducts of obesity. Obesity prevention, obesity cure, obesity complication management, all these NCCPs are heavily in vogue today. India has become one of the global leaders when it comes to obesity, and the numbers are actually on the rise. To start with, we always talk about prevention of obesity, diet, exercise. I am a bariatric surgeon and I do bariatric surgery in the morbidly obese, in the extremely obese people who have no other options. But these days, we've got more options which come between our diet exercise phase and bariatric surgery. And there are basically two options. One is the endoscopic balloon options, and now we have the pharmacotherapy, which has come in a big way. So pharmacotherapy is an option which many patients are seeking. Also, pharmacotherapy is combined with other modalities of treatment. So you could be having a diet exercise program with pharmacotherapy. We could be putting in a gastric balloon and giving pharmacotherapy. Bariatric surgery patients of mine who have not lost enough weight or who have regained weight again will be given the opportunity of pharmacotherapy. So a lot of things are there. A lot of developments have taken place in the recent past. A lot of research is going on for the future. So to start the program, I will invite the first speaker, which is Dr. Priyamvada Tagi, who is a DM endocrinologist and is at Max Hospital, Patparganj. She's an author of multiple publications in endocrinology, endocrine surgery, and has been an educator for diabetes. A lot of social media programs and campaigns have been done by her. So over to Dr. Tyagi to give us the first talk on this session. Thank you.
So thank you for the introduction, sir. A very warm welcome to you. So as sir rightly said that obesity is the mother of all diseases. Now, obesity over a period of time has undergone changes. It is more than just calories in versus calories out. It is a chronic disease. And the word chronic disease is important because the medications that are going to be talked about in upcoming sessions, because of the word chronic disease, there is no particular timeline for which this particular medicines need to be taken. Now, this is important for doctors and patients to understand. So, here we are going to talk about why obesity is a chronic disease. So let's talk about the epidemiology and the pathophysiology first. Now, prevalence more common in females as compared to males. 4 in 10 women are affected by abdominal obesity, and the recommended waist circumference is exceeded almost 40 to 50% of the females. Now, if you see the prevalence by region, it is almost equivalent north to south, east, west, somewhere lies between 60 to 64%. If you see, there are certain areas where the prevalence of obesity is very high, and that would be Uttarakhand, Haryana, Punjab, and in the south in Andhra Pradesh, Tamil Nadu, and Kerala. Probably a statistical factor, but it is important to understand almost 60% prevalence of obesity across the globe. Now, there are a lot of factors which contribute to obesity. It could be epigenetics, environmental, social, cultural, behavioral, physiological, and genetic. So first, let's talk about the neuronal and the hormonal communication. So you have the mesolimbic system, which is responsible for the hedonic eating. So that I like eating chips, so I am going to eat chips. I'm going to watch Netflix and I'm going to have lots of savory items. So this is hedonic eating. The like and the want of savory food items. The second is the homeostatic eating, which is necessary for the calories that your body needs to function for day-to-day work. It depends on the second appetite and the energy expenditure. And all of this is regulated by the hormones in our body. So from the intestine, it could be GLP-1, CCK, peptide YY. From the adipose tissue, we know it is leptin. From the pancreas, it is insulin. From the stomach, it is no, adipocyte dysfunction is probably the most important thing that happens early in the course of obesity and obesity-related complications. So you have a normal adipocyte in a normal individual, but in obesity, the adipocytes increase in number as well as the size. And this dysfunction is what leads to visceral fat accumulation. So then you have fat accumulation everywhere, liver, pancreas, renal sinus, intermuscular, or mental region. And this adipocyte dysfunction, progressive inflammation, development of insulin resistance, and ultimately leads to insulin resistance and all the downstream complications. So adiposity is one of the most important components of the word, the disease syndrome, which is obesity. So now obesity is not what it should be. This should be known as adiposity-based chronic disease. So this is what all the major endocrine societies across Southeast Asia, including Endocrine Society and the South Asian Federation, say. Also, the American Society for Metabolic and Bariatric Surgery says that it should be recognized as a chronic disease associated with chronic low-grade inflammatory state and immune dysfunction. And the change in terminology over the decades is important because obesity is now a lifelong disease and we need to keep working on it forever. So, when we were foragers, so whatever calories we consumed, all of it was expended in hunting, protecting ourselves from predators. But over a period of time, as the empty calories became more available to us as a lifestyle has gradually become sedentary, your body does not want you to lose weight. As soon as you make a lot of effort and you lose weight, body starts producing hunger hormones. So maintaining weight loss is the most difficult challenge that we have. So following weight loss, your body needs to decrease energy expenditure, increase hunger hormones, decrease satiety hormones, and ultimately what it does more is for you to lose weight. So the increased drive to eat and the decreased energy expenditure now creates a perfect physiological storm for weight regain. So it is just to say that as soon as you stop making efforts by by exercise or by dietary modifications, whether you are after bariatric surgery or on medication, you will regain all that. So what do the obesity treatment guidelines say? So the Endocrine Society Clinical Practice Guidelines, we can talk about it a little bit, published in 2022. So along with all other major endocrinological and bariatric societies across the world, we now call it as a chronic relapsing progressive disease defined by excessive adiposity. So we do know that the BMI criteria for Asians are a little different as compared to Caucasian population. More important than just BMI would be waist circumference and waist ratio. Body fat percentage is a wonderful clinical tool, but it is not readily available everywhere. So waist circumference more than 90 centimeters in men, 80 in women, and waist ratio more than 0.9 in men and 0.8 in women. And if you give just 5 minutes extra in OPD practice, we can actually do this for patients in 24. So Edmonton obesity staging system, this is the universally adopted because this is more detailed and includes all the management options and a variety of stages. So stage 0 would be a perfectly healthy person where you have no apparent obesity related risk factors or physical symptoms. So herein is the primordial prevention, that you prevent the person from becoming obese. Stage 1 is subclinical obesity with risk factors. Stage 2 is established obesity and related chronic diseases. Stage 3 is when you have established end organ damage, and so then from stage 2 onwards, you need to start medication therapy. And then stage 4 is potentially end stage, and such severe disabilities which cause severe impairment of the quality of life of the patient. So, what do the guidelines recommend? So, the European Association recommends that you should develop therapeutic goals based on the stage and severity of the disease, and while improving the further weight gain and obesity related complications. Now, guidelines recommend that these should be individualized or based on medical history, and more importantly, present or absence of certain comorbidities. Also, the degree of weight loss that you want to achieve in an individual patient has to be individualized depending on the complication status. As I talked about again and again, adiposity is chronic disease. So this identifies a chronic disease, helps doctors and patients work for a very long time on an individual basis, alludes to precise pathophysiology cases, and avoids the stigma and confusion associated with the term obesity. Like it is taught to us while in residency that whenever a patient comes to you, you don't just directly start talking about obesity. You have to ask the patient first whether you think this is a concern. If and only if the patient says that yes, I think it's a concern and I want to do something about it, then you talk about following further plan. This is a simple guideline, but a wonderful guideline. It says that according to different BMI stages, what should be done. So lifestyle modification is the most important thing. There is not enough words to say that lifestyle modification should be followed in each and every patient that comes to you, whether that is overweight or obesity, or you want to prevent obesity in an individual, especially who has strong genetic risk. And so that would be primordial prevention. So lifestyle modification is important for everybody. Pharmacotherapy will start with BMI level 27 who has adiposity related issues. And surgery or could be recommended when the patient's BMI is if the BMI more than 40, then the first preference is usually surgery. So now coming to the lifestyle therapy, which is majorly component of two parts. One is the diet, which is a hypocaloric individualized diet, and the second is physical activity, which is 300 minutes of moderate intensity physical activity. Now, diabetes prevention program has been, our standard for a very long period of time for all endocrinologists. Minimum 7% weight loss to diabetic modification of hypocaloric diet can prevent onset of diabetes and can reduce diabetes. And 58% reduction in incidence rate of diabetes with just 150 minutes of moderate intensity exercise. That comes to about 20 to 25 minutes. The major problem with lifestyle intervention, if we talked about it, that your body does not want to lose weight, that whatever weight you lose with a severely hypocaloric diet, you tend to regain over a period of time. So if the patients have lost somewhere around 15 kgs or 20 kgs, and they are going to regain it at the end of 1 year. So most participants will regain 5.5 to 6.5 kgs on an average after the diet has ended. And over 5 years, 79% of the weight lost has been already regained. So maintaining that initial weight loss is a challenge that we face on an everyday basis. So following weight reduction, there are hormonal changes that persist over a period of almost 1 year. So the hunger hormones grow up, the ghrelin goes up, and the satiety hormones become low. So body produces hunger promoting hormones, and this change leads to changes in hunger drive and ultimately leads to progressive gaining of the weight. Coming to the pharmacotherapy for obesity management, is indicated for any person with BMI more than 27 with comorbidities or more than 30 kg per meter square. So if you are in a clinic basis and you are a patient, you have a patient who is considering pharmacotherapy, then you need to provide information to all the available medicines in India. Up to 3 months back, there was only hardly one or two medications available in India for weight loss. Now, now that list has become a little common. Also, patient should be counseled whether he or she is eligible for pharmacotherapy. We need to decide the goals of therapy, how much weight we want to achieve, over how many months or years, and then patient values and preferences should be taken into account. You start the medication, whatever medication you and your patient have chosen for yourself, and then monitor every 3 months. You can assess efficacy on 3 to 6 months. If the therapeutic goals that you decided on the first visit are met, then you can continue with the same treatment with gradual dose escalation, and then finally deciding on a maintenance dose. If not, you can add or substitute another medication. And for how long these medications need to be continued is another discussion point for you and your patient. So the currently available medicines for obesity management in India is tirzepatide, semaglutide, orlistat, and liraglutide. So tirzepatide, you start with 2.5 milligrams subcutaneous once weekly, and every 4 weeks you increase. Maximum dose could be 15 milligrams. Semaglutide, you start with 0.25 subcutaneous every week. For a glycemic control, dose of 1 milligrams is enough, but for weight loss, dose of 2.4 milligrams is recommended. Orlistat, now it is being used less and less common because of better options being available, because more frankly speaking, patient feedback with Orlistat is that the adverse effects are usually embarrassing and the weight loss achieved is not great. But still, if you would like to use it, it is 120 milligrams, ready with fat content. So, as per would guide us in a better way, recommendations for metabolic and bariatric surgery for people with BMI more than 35, with or without obesity-related complications. And previous guideline was recommended with at least one obesity-related disease with BMI more than 35 or anybody with BMI more than 40. And there are several devices which have been approved, and it's a multidisciplinary approach. So these are the options that are available: sleeve gastrectomy versus Roman gastric bypass and adjustable gastric bypass. The weight loss differs. The resolution of diabetes and hypertension ranges somewhere between 30 to 35%. The mortality rate is not significantly different. The side effect profile is a little different. The loss of risks are different. Now, most of these complications are also depend on the surgeon and the rate of number of procedures that a center is doing. So all of these values could be individualized. So summarizing, obesity is officially classified as a chronic disease by all leading health authorities. The epidemic is escalating with staggering numbers in across the world, but especially in developing countries and poor countries like in Southeast Asia. It results from a complex interplay of genetic, environmental, social factors and need to include personalized lifestyle changes with pharmacotherapy and surgery. Maintaining that initial weight loss is the most difficult part that we will face in your practice.
Thank you very much. We'll have common questions at the end. So if you'd like to just join us on the dais. And with this, I will invite our next speaker, Dr. Rajesh Rajput, who is the Director of Department of Endocrinology at Medanta Gurugram. And he's had multiple accolades with editing many books and has contributed many well-known textbooks in diabetes endocrinology. I think a change of sequence, and I'll now invite Dr. Rakesh Gupta, my colleague at Indraprasth Apollo Hospital, the senior consultant in internal medicine with great interest in obesity, and he also runs a course for this. He has vast experience over 25 years and has been uh, running the diabetes course with the Apollo University. And over to Dr. Rakesh Gupta.
Rakesh, I just want to tell you, there will be first ring at 2 minutes left, not at 1 minute left. So don't get upset. The first ring, second ring is 1 minute.
Thank you very much, sir, and thank you, Dr. Arun Prasad, for your kind words of introduction. I think these are exciting times for all of us, clinicians, basically because of this drugs which have come into our armamentarium. And I think everybody is familiar. I think most of our patients are sensitized, and I think media has also gone overboard over the last few months. I think even our honorary prime minister nowadays has been talking about obesity and challenges, and I think I hear radio jingles and ads almost every day whenever you're passing by. So I think obesity has come into a lot of focus, and I think very much so it should be, because if almost every second patient is obese in our country, then why not kind of tackle the problem? And that would be really, like everybody's been talking, mother of all problems, and would take care of so many things. So today I'm going to talk about this topic which has been given to me is about the Surmount trial, Surmounting Obesity with Tirzepatide. Tirzepatide is the focus today, and it's come into our armamentarium very recently. I think in the last week of March it was introduced in our country, and we have started using it, and experience with this is growing day by day. And where are we standing today, and what are the trials telling us? That's what I'm going to talk about that. So the mechanism of action is very novel. I think everybody is familiar that tirzepatide is basically a GLP-1 plus GIP analog. The other GLP-1 analogs which we are familiar with, we have for some time, but now this is the novel, novel mode of action. This is a GLP-1 analog plus GIP analog. It is a dual mode of action. GIP is a nutrient stimulated hormone with multiple sites of action, and glucose dependent insulin secretion. In healthy individuals, GIP is estimated to contribute 50 to 70% of the incretin. I think most of us know that incretin effect is the effect which basically the short form is intestinal secretion of insulin. So this is dependent on the oral as it is taken. And GIP is estimated to have more effect than a GLP in these cases. So the multiple actions of GIP on various organs of the body, it has pancreas, the glucagon, glucose-dependent glucagon secretion. Then it's the CNS action also, which leads to inhibition of fluid intake, inflammatory and neuroprotective effects. Action is on hypothalamus and brainstem, antiemetics and neuroprotective effect. Action on the fat, which we just mentioned, insulin-dependent fatty acid uptake and mobilization, regulation of the glycolysis and lipogenesis, manufacturing medical and there is increased adipose and plasmic blood flow as well as the vasculature. Also, independent increase in adipose blood flow and that effect on the endothelial cells as well. Yeah. This is where the action is, and GIP is an important regulator of lipid metabolism, as you are well aware. Looking at GIP adipose has been well studied. The GIP receptor is highly expressed in human adipocytes, and upon postprandial conditions, upon fasting conditions, in both conditions, the GIP increases the glucose and lipid uptake into adipocytes in an insulin-dependent manner. GIP also increases the adipose tissue blood flow in an insulin-dependent manner, further enhancing GIP. Um, and yeah, further enhancing GIP-induced insulin utilization in the postprandial state, and blocking GIP receptor decreases fatty acid uptake in the adipose tissue, resulting in tropic fatty. These are the mechanisms of action in postprandial condition. In fasting condition, it mobilizes lipids from adipocytes, allowing the utilization in adipose and non-adipose tissues. So basically, when you have a GIP and a GLP-1 receptor co-agonist, like you have peptide, it promotes clearance of lipids from the circulation. So it can show greater improvement in the postprandial lipid metabolism as compared to the human. There is a greater triglyceride and free fatty acid suppression in the hyperglycemic plan, and they can also increase the fatty acid oxidation to a greater extent in GLP when agonist growth. So these are some of the actions which topic that comes to us with, and something which is familiar. So tirzepatide, the molecule which we're talking about today, is a single molecule designed to activate both the GIP and GLP-1 receptor. The structure is based on the native GIP sequence. The activity on the GIP receptor is similar to the native GIP hormone, whereas the activity on the GLP-1 receptor is a bit lower as compared to the native GLP-1. The mean half-life is approximately 5 days, and that is why we can do it once a week. That is what the dosage has come with. And one big thing which probably is a real good take-home message is that you don't require any dose adjustment in any patient with renal or hepatic impairment. So I think that's also what we are seeing practically over the last 3 4 months. There's no we have no problem with patients who have the renal and hepatic impairment. Many of our diabetic patients do have these problems in the very beginning. So Mounjaro is a brand name, and it addresses some important biological adaptations of obesity. Like we talked about GIP and GLP-1 receptor agonism, it reduces the appetite and calorie intake by increasing feelings of satiety and decreasing feelings of hunger. It reduces the intensity of cravings and preferences for high sugar food and high fat foods. And I can vouch that most of our patients who have started using this drug, they do come back to us and say that भूख नहीं लगती है अभी इतनी इतना appetite का इतना craving नहीं है उनको. And of course, there has to be some mechanism to be used. The GIP receptor agonism in adipocytes, it regulates the glucose uptake and regulates lipid uptake and lipolysis by binding to human adipocytes and creating GIP receptors. And through the combined action on the GIP and GLP-1 receptors, Mounjaro lowers the body weight, resulting in greater fat mass loss and lean mass loss. So that's another message which we must have, that the loss is more in the fat mass rather than the lean mass. What are the approved indications for this drug as of today? Of course, it's a oral hypocritic, basic not oral, it's an anti-diabetic drug. Basically, it is indicated as an adjunct to the diet and exercise to improve glycemic control in adults with type 2 diabetes. That is where is one indication. But where it probably scores a bit more is basically for chronic weight management. It is indicated as an adjunct to a reduced caloric diet and increased physical activity for chronic weight management in adults with an initial body mass index of 30 kg or more, which is considered obesity, or 27 kg per meter square or greater, which is considered overweight, in the presence of at least one weight-related comorbid conditions. For example, blood pressure, dyslipidemia, type 2 diabetes, liver cardiovascular disease. And I think it goes without saying that any patient with walking to a gender would, by and large, would have definitely more than one comorbid. All the patients will tend to have more and more comorbidities. So it's indicated for type 2 diabetes as well as for management. So a lot of research has gone in and a lot of trials have gone in, and we got a lot of evidence about using this drug. So basically, surpass and surmount programs were basically meant to tell us how well it has been studied. So Mounjaro was studied in these comprehensive development programs, more than 6,200 participants across different stages of type 2 diabetes with active comparators. So basically, it was seen as a five kind of trials, surpassed 1, 2, 3, 4, 5. One, it was compared as a monotherapy versus placebo, and surpassed 2, it was seen versus semaglutide, which we know is a GLP-1 analog, and this will add on to metformin. Surpassed 3, it was compared with insulin deglutide, again add on to metformin with or without SGLT2 inhibitors. In surpassed 4, it was compared with insulin glargine in addition to the standard of care, and surpassed 5, it was compared with placebo as an add-on to insulin also. So it was added to basal insulin glargine with or without metformin. So surpassed trials over a period of time have reinforced the fact that this drug for weight management was evaluated also in a robust clinical trial program amongst 5,800 participants. We're talking about all the surmount trials, 1, 2, 3, 4, 5. And Mounjaro was used, the dose which has been kind of told to us for using Mounjaro is to start with 2.5 milligrams, use it for 4 weeks, then go on to 5 milligrams for 4 weeks, then go on to 7.5 milligrams for 4 weeks, then 10, then 12.5, and the maximum tolerated, the maximum dosage which is recommended is 15. So not everybody can tolerate that kind of dose because of the side effects. So you go up every 4 weeks. If a patient can't tolerate, you come back to the previous dosage. If a patient can tolerate, try to increase it to give him maximum benefit. So basically, these trials have been seen with Mounjaro 5 milligrams, 10 milligrams, 15 milligrams in comparison with participants with placebo. And as you can see, a fair amount of participants have been seen, and these studies have been almost 72 weeks to 84 weeks and 88 weeks also. So Surmount 1, 2, 3, 4, 5, all these trials compared Mounjaro in various doses as compared to placebo. And in Surmount 5, which is another important trial, compared Mounjaro maximum tolerated dose versus semaglutide, maximum tolerated dose, which is a GLP-1 analog. The Surmount trial, if you look at, basically investigated tirzepatide 5 and 15 versus placebo in patients with overweight or obesity with complications, excluding diabetes. The diabetic patients were not taken in this case, and patients were studied over 72 weeks. This was a phase 3 multi-center trial at 119 sites in 9 countries, and that basically the endpoints were the change in weight and percentage of population with weight reduction in. So what it showed was staggering results. The weight reduction was seen as early as 4 weeks, and it was a powerful weight reduction which was seen at 72 weeks with tirzepatide. So 16% average weight reduction in body weight was seen with tirzepatide 5 milligrams, which is comparatively a low dose at 72 weeks. And if a patient managed to kind of tolerate the dose of 15 milligrams, then it was seen that over 72 weeks, which makes it almost 1 year and probably 3 months, 22.5% weight reduction in body weight with tirzepatide at 72 weeks. These are phenomenal results. These are kind of results which we have never tackled and we have always only dreamt of. 22.5 is a solid average reduction in weight, which was shown by Surmount trial. So majority of people with obesity achieve more than 10% weight loss with tirzepatide 5 milligram, and approximately two-thirds of patients with Mounjaro 15 milligram experience more than 20% weight loss. So significant, kind of weight loss was seen in these trials. More than 20% weight loss is a very significant loss, which we saw in most patients. And they also showed and experienced improvement in body composition also. And this was evaluated in a sub-study in Surmount 1 using a DEXA scan. And these studies suggested that there was a greater reduction in the fat mass rather than the lean body mass, leading to an improvement in the body composition compared to placebo. And this reduction was accompanied by a reduction in visceral fat. So the results suggested that most of the total weight loss was attributable to a reduction in fat tissue, including visceral fat, which really made us everybody sit up and take notice of this drug. And apart from that, there were pleiotropic effects also, and now most of the clinicians have become greedy. We want better results. We want more, pleiotropic effects. And Mounjaro ticked a lot of good boxes there also. It was seen in these trials that systolic blood pressure decreased by around 7 to 8 millimeter mercury, diastolic decreased by 4.6 to 5.5 millimeter, triglycerides decreased by 24 to 31%, HDL cholesterol increased, and LDL cholesterol also showed a reasonable decrease by 5.3 to 8.6%. Now, what happens if you discontinue Mounjaro? When in practicality, if I ask the patients who have been coming to us for last 4 months, which we've used, there are two questions they ask. The first question is, are there any side effects? And second question is, how long do I use the drug? So the answer to these questions, of course, lies in the trials what they have taught us. Surmount trial was meant basically to see that basically when you stop the drug, what happens, and does anything happen, does anything change, and we go to the maximum tolerated dose. So patients were randomized at 36 weeks to those who were given the drug further or those who were not given the drug further. And it was seen basically that those who continued with Monjaro after the lead-in period continued to lose weight, and those who stopped, they regained a bit of weight, which was almost went up to 9.5%, which is not as much as before, but still they bounced back. So the total weight reduction in participants on Monjaro was around 26%, but 9.5% in participants who stopped taking Monjaro at week 36. So common sense also says the same thing. If you stop the medicine, of course, the bounce back happens. And that is what we have to look at all those conditions. Adverse effects were studied in the Surmount program, and by and large, we know there are gastric side effects from nausea and vomiting, diarrhea, constipation. And it has a similar profile with other incretin-based therapy. And that is why we go slowly and sensitize the patient and go for the dose escalation. But most of them, if you sensitize the patient, it's generally good. So basically, to summarize what I've talked about in the last 15 minutes, tirzepatide or Monjaro, which we have now, has significantly reduced weight in all these trials by almost 16% with 5 milligram. That is the dose which we have till now. Probably the other doses will come very soon. And 22.5% with 15 milligrams, which is significant. And also showed improvement in blood pressure, waist circumference, triglycerides, and HDL cholesterol. And the most common side effects were gastrointestinal and meningitis. Generally, they were mild to moderate in nature. So I think with that, I thank you for your patient hearing. And I'll be happy to talk about things when we talk about it. Thanks. I'll join.
Thank you, Dr. Rakesh Gupta. So now I would like to invite Dr. Rajesh Rajput, and his topic is tirzepatide versus semaglutide, evidence from head-to-head clinical trials.
The time is not the foundation for me because there is no one is going to speak. So you are here for night watch, right? So we know obesity is a big problem, and probably even all of us who are sitting in this hall, some of us are obese. May not be diseased, but obese. So we have to understand when we are going to treat obesity. That is most important. Simply by going cutoffs, which has been lowered. Before I come to the lecture, because the last lecture, the biggest paradox. For Asian Indians, the cutoff for obesity is now more than 25 kg, and overweight is defined as more than 23. But if you see the recommendation of all the drugs available, the recommendations are BMI more than 30 or more than 27 with one or other comorbidity. So what we are going to do for those who are more than 25 and more than 23, which are our current recommendations. So there are some paradoxes which are available in our legal domain, in our literature, but definitely obesity is there, it's a big problem. Few months back, we have a big challenge. We do not have any drugs. And whatever is available in our country is not effective for management of obesity. That's the effective drug. Hardly any drug can cause more than 10% loss of body weight. So we have a big issue. In US, last 4 years, these drugs are available. Huge demand and generic versions even are available. Now, these are available to us from last more than 4 months. Two such molecules are available. One is tirzepatide, which is a dual incretin, GIP plus GLP agonist. Another is pure GLP-1 agonist, semaglutide. Now, there are some small differences we can take up in question and answer. There is a difference in dose used for diabetes purpose. There is a difference in dose used for obesity purpose. Now, these are the two molecules which are available. For all practical purposes, we are discussing today about management of obesity. But I am going to discuss with you head-to-head two important trials, tirzepatide versus semaglutide, one in obesity patients, other in type 2 diabetic patients. Remember, with tirzepatide, there are two clinical programs. One is Surmount program, where you are going to treat your obesity. So that is a data. When you are seeing type 2 diabetic patient, the program is SURPASS trial. Now, why it is important to understand these two trials differently? Because the amount of weight loss is also different in two sets of trials. In SURMOUNT trial in pure obese individual without type 2 diabetes, up to 22% loss of body weight as has been shown. But if you see the SURPASS trial for type 2 diabetes, up to 12 to 13% loss of body weight is seen. So therefore, in routine clinical practice, when you are going to choose your patient for use of this drug, we should give the realistic expectation that in clinical trial data in patients who are suffering from type 2 diabetes and obesity, that amount of weight loss is not seen as seen in pure obese individual without diabetes. So this is a very important differentiation when we see type of patient. Now let's start the lecture with tirzepatide versus semaglutide head-to-head. I have told you I am going to discuss these two important trials. Now, this is an important slide for why I am telling you GIP was discovered even before GLP-1. But as the world is run by economy, we do not have drugs. So we have never discussed about GIP. Now, also remember, till today, our understanding about exact mechanism of action for GIP in weight loss is not known. We do not know where this GIP is going and acting in the brain. Very recently, 15 days back, a new clinical trial with GIP antagonist has been published. Here we are talking of GIP agonist. GIP antagonist once in a month for obesity, same weight loss, which means both GIP agonism and GIP antagonism is causing weight loss. So there are many unanswered questions surrounding GIP, which will be solved probably in future as mechanistic studies will evolve. But then, when you understand this slide actually summarizes the difference between GIP and GLP. And one very important difference is that GIP acts on the central nervous system and reduces nausea. GLP-1 increases nausea. So probably this is a basic concept why this molecule is developed, that when you combine GIP with GLP, people will suffer from less nausea. Although in real world, this is not the case. Still, individual in whom you are beginning this molecule, they suffer some degree of nausea and GI side effects. There are other actions, I will not repeat them, already has been discussed about GIP action. But then this slide is important to highlight the importance of understanding GIP. Whenever you eat something, or after this we are going for a dinner, you are going to eat something. Whenever you eat something, GIP or glucose is responsible for 33% of the insulin secretion. GIP, which is secreted from the gut, is responsible for 44% of the insulin secretion, and GLP is responsible for only 22%. So it is GIP which is more powerful, but because of some reasons, it has taken a backseat. Now, with the availability of the drug, it is more and more going to be discussed. And we now know that GIP is also an important incretin hormone, which is responsible for control of glucose. So let's start the two trial after very brief because of the 20 minutes time allotted to me. Otherwise, we would have discussed at length about various mechanisms. Now, such type of patients are not uncommon. Overweight, may be having some comorbidity, may not be having some comorbidity. They wanted to lose weight and they have tried diet, exercise in past, but it is unsuccessful. Why it is unsuccessful? As soon as you start diet and exercise, your body homeostatic mechanism or defensive mechanism against weight loss comes into picture. Remember, in human beings, evolutionary mechanism, energy conservation is principle of the body. So as soon as you start doing diet and exercise, these evolutionary energy conserving mechanisms comes into action, which are various hormones, which probably Priyamvada has shown you in the first lecture, and they prevent you from losing an amount of weight. So that is why it's a common problem. People will come to you, अक्सर डाइट और एक्सरसाइज से थोड़ा वजन कम हुआ था, तो उससे तेजी से बढ़ गया और उससे कम टाइम में बढ़ गया. हम सब ने एक्सपीरियंस किया. Which means there is a problem and we need solutions to it. So drugs are probably the solutions which we are now having and we are discussing. So first I am discussing a very important trial, Surmount 5, which has been published very recently in 2025. The Surmount 5 is a head-on trial. Head-on trial for tirzepatide versus semaglutide in patients with obesity. Now, this is a clinical trial design of the Surmount, as you see, people suffering from obesity, inclusion criteria BMI more than 30 or more than 27.5 with one or the other comorbidity without diabetes. One of the patients with this study in Surmount 5 is having diabetes. So diabetes is excluded. Patients were given randomized into 1:1 arm. One arm is given tirzepatide starting from 2.5, increasing gradually to up to 15 or 10 milligram depending on the dose which patient has tolerated. It means gradual escalation every 1 month, minimum 4 months it takes, and then for semaglutide 0.25 milligram gradually escalated to either 1.7 or 2.4. Semaglutide is also available now in our country, so it is important to know the comparative data. It's a phase 3 multicenter randomized open label trial. The first two molecules have different phase. It cannot be closed. It's an open label trial. 750 participants were studied. 72-week trial. Primary endpoint is percentage change in body weight from baseline to week 72. Now, what are the results? At week 72, with use of 10 or 15 milligram of tirzepatide, 21.6% reduction in body weight. With use of semaglutide 1.7 or 2.4 milligram, 15.4% reduction in body weight. So definitely percentage wise it is much higher, and it is statistically significantly more with use of tirzepatide. Now 1 in 3. Now this is actually a very good figure, because before that bariatric surgery is the only way, whatever type of bariatric surgery we are talking, where we can achieve more than 20% or even sometimes more than 25% loss of body weight. Now in Surmount 5, they have observed that with use of tirzepatide, 10 or 15 milligram dose, more than 25% weight loss is observed in more than 35% of the patients, which means every one out of 3 patients, you are giving tirzepatide, escalating the dose to 10 or 15 milligram, they are going to lose 25% of the body. Now, when we see this with semaglutide, less than around 20% of the patients are losing 25. More than 20% is also a very good figure, but the results with tirzepatide are drastic. Close to 55%, which means almost every other patient is going to lose 20% of body weight. When we see it with semaglutide, it is around 3%. So these are some of the results which shows that Mounjaro is probably providing bigger weight loss. Now, along with weight loss, there is another very important component, which is our waist circumference, because that is a marker for visceral adiposity. And we know visceral adiposity is more dangerous as compared to subcutaneous adiposity. Now, in Surmount 5, they have also measured waist circumference. And with use of tirzepatide, waist circumference is reduced by around 20 centimeter, which is around 7.9 inches. Wonderful reduction. Obviously, every new group, some of the patients who are even bringing molecules from outside, and now we have more than 200 patients. They are saying कि डॉक्टर दवाई तो बहुत अच्छी है, पर आपने नुकसान करा दिया. अभी एक नीति से ऐसा मतलब मेरे को सारे नई पेंट जानी चाहिए. So this is actually happening with those who are using this molecule from last 5 months. There's a huge changes in waist circumference. Now, next important subset of patient which often we see in routine clinical practices, type 2 diabetes and obesity. Now again, for type 2 diabetes and obesity, with tirzepatide, it has been studied in now SURPASS trial. SURPASS has been discussed. SURPASS trial, there is a trial where semaglutide compared with tirzepatide in patients with type 2 diabetes. And I am going to discuss that is SURPASS 2 trial. Now, this is study design of SURPASS. 4 arms, one is more randomization. One arm is given 0.25, 0.5, and 1. Other arm is given tirzepatide 2.5, it is 15. I do not know how much of you are awake, but you will be seeing here the dose of semaglutide is only 1 milligram. What we have discussed in obesity, 2.4 milligram. Now, this is because these two drugs are sold with different names in United States of America and Europe for two different disease indications. Ozempic, Wegovy, Mounjaro, Zepbound. But in India now only one name is available. There are some reasons we will discuss later. Now, This is the only dose. 1 milligram is the only dose approved at the time of trial in the United States for type 2 diabetes. So therefore, the dose is only compared up to 1 milligram. After this, now even in United States of America, in type 2 diabetes, up to 2 milligram dose is approved. Now we do not have data for comparison for 2 milligram dose because some of you are going to ask 2 milligram USA क्यों कर दिए? We do not have that comparative data. The surpass 2 comparison has been made with up to 1 milligram of semaglutide and with 15 milligram of tirzepatide. Now these are the results. If we see the results of surpass 2, again Mounjaro supersedes or has shown better results as compared to semaglutide. All three doses, 5, which is available in our country, and soon we are going to have 10 and 15 because the company has decided to make finally a quick sell. It is only available to us in vials, tirzepatide. So all three doses, 5, 10, and 15, are superior to 1 milligram of semaglutide in patients of type 2 diabetes and obesity. As you see, the lowest dose 5 milligram available to us, we are using 2.1% HbA1c reduction and 1.9% with 1 milligram of semaglutide. When we see the 15 milligram dose of tirzepatide, it is 2.5% HbA1c reduction. Now, moving from that, how many patient achieves an HbA1c of less than 7%? As you see the numbers, more than 90% achieves HbA1c reduction of less than 7 with 15 milligram dose. But what is most important? This is again a common question those who are practicing diabetes, that your patients are coming diabetes remission control because they have read in the literature, lots of fat rates are going on. Now, in this trial, they have shown that percentage HbA1c less than 5.7, which is normal HbA1c, even not pre-diabetes. 51% of the patients who were given tirzepatide 15 milligram dose, they have remission of diabetes. And 20% of the patients with 1 milligram semaglutide have remission of diabetes. So it is practically possible that now if patient continues these drugs and are in early phase of type 2 diabetes, probably achieving a normal glycemia, euglycemia, and normal HbA1c is possible. Now this slides as you show again should have weight loss across all the three categories. I have started my lectures telling you. Now you see Mounjaro loss of weight 15 milligram, only 12.4 milligram. 12.4 kg, and it was 22 kg. If we were talking of obesity, whenever we are treating type 2 diabetes with obesity, we should have different expectations. So this is very important because your patients are going to ask, आपको तो ज़्यादा 20% लॉस होगा, 25% लॉस होगा, मेरा तो नहीं होगा. So in type 2 diabetes, results are different. But again, in Surpass 2, it has been shown that the weight loss achieved with tirzepatide is superior to 1 milligram of injectable semaglutide. The composite outcome is something which we have again started talking about since the time GLP-RAs are available to us. Now, what is composite outcome? Achieving HbA1c of less than 6.5%, weight loss more than 10%, and no clinically significant hypoglycemia. Now, practically, this is a dream in diabetes practice to achieve all the three targets together. But now, with the availability of GLP-1RA, we are doing this. And as you see, with Mounjaro 15 milligram, 60% of the patients are able to achieve all the three targets. And when we compare it with semaglutide, it is 22%. So composite endpoints achieved with Mounjaro are significantly more when we compare it with semaglutide 1 milligram. Adverse event, I will not spend time. You have listened. Rakesh, we have already told you most of the adverse events are GI. Therefore, we have to teach our patient when we are starting these drugs that you are going to see these type of adverse events. So friends, in people with obesity, with use of tirzepatide up to 21.6%, loss of body weight, which is superior as compared to semaglutide 2.4 milligram, 15.4. In patients with diabetes and obesity, with tirzepatide 15 milligram up to 13% weight loss, which is again superior to semaglutide weight loss. Now, initiating tirzepatide, we are using it. I do not know how many of you have not used. So, some practical, you can start with 2.5, gradually escalate 4-week interval to 5 milligram, 7.5, 10, and 15 milligram. There are many resources. You, you can start it with any type of antidiabetic agent. You can give it metformin, you can give it as GLP-2, you can give it other drugs. But remember, if you are initiating GLP-1RA with sulfonylurea and insulin, there is a risk of hypoglycemia if you are starting at a baseline HbA1c less than 8.5%, because patient glucose control is going to improve drastically. So therefore, reduce the dose of HUs and insulin. But if you're starting baseline HbA1c is 9%, 10%, then practically really I does not reduce the dose because these patients require much higher reduction in HbA1c. Although Rakesh has highlighted no dosage adjustment for renal and liver disease, but careful. Please do not initiate in patient with CKD and stage renal disease. There are no studies, whatever companies may claim, for any GLP-1R. Number two, for again childhood category liver failure, please do not initiate. All such patients, insulin is the treatment of choice. No adjustment, therefore, in hepatic and renal impairment. It is a broad statement. That is why I have specified. Not recommended. Remember, tirzepatide is not recommended at an age less than 18 years of age. Now, this is very important. We are seeing teen obesity. Out of excitement, some of us are going to start. It is not recommended and not studied as of now. We do not have results for teen obesity less than 18 years of age. For semaglutide, it is different. We have step teen study where it is approved. These are some of the practical consideration. If your patient has pancreatitis, please do not use it. Pregnancy, not recommended. Again, not recommended. Breastfeeding, people will come to you in postpartum stage. I want to lose weight. Breastfeeding, again, no safety data, not recommended. Please do not use. Diabetic retinopathy, again, because people with diabetes and obesity, if they have proliferative diabetic retinopathy, maculopathy, we have some concerns with GLP-1RA regarding exacerbation of maculopathy. Do not use it. These are some of the careful areas where you should be careful. These are ways to mitigate GI side effects. I think this has already been discussed that GI side effects are the most common side effects. Therefore, practically, whenever you're starting GLP-1RA, GIP or GLP-1RA, you have to educate the patient, get the printed pamphlet of such type of things and give it to the patient so that they can read at leisure, they can follow it, they can avoid development of GI side effects, which are the only limiting factor. What about skip dose? This is again going to happen. Although we often says that giving once a week improves compliance, reverse also happens. Sometimes when we are going to give once a week, patient forget to take. He has gone on a picnic, forget to take. Then what to do? So if it is less than 4 days, you can give the dose immediately. But if more than 4 days has passed, then your patient should take a scheduled dose. Should not take 2 doses together. So this is a again practical important consideration. So probably I finished in the time. Thank you very much. Please join us for the panel discussion. And we'll move on to the panel discussion now. And I think as this is a cardiology meeting, we will start with some questions which are really related to the cardiac as well as then the questions. So to start with, Dr. Modi, what is the current evidence or current usage of these GLP-1 agonists when it comes to cardiovascular diseases in obese with or without diabetes?
Repeat the same which I've been depending on which compound you are using.
So what indications would you use? Like would you be using it for arrhythmias, LVH, or
It depends on the type of patient, depends on the kind of practice. My experience is that explain properly, spending time with the patient. Majority of my patients, I don't know why and how, they lose weight on very proper diet modification. And I insist on the patient, weight is only connected with the diet. We all eat 2 to 3 times of whatever body requires. Body requirement is extremely low, written in our Shastras and Vedas, Mahar. So fortunately, I'm a fortunate position that majority of my patients will lose some kind of weight. And I'm not talking of 120 kg, 140 kg patients, ordinarily obese patients. And mainly by diet modification. It's not the exercise which reduces too much of weight. So I will use these drugs in the same indication if they are not losing weight, if they have associated comorbidities, like epidemia or already have coronary disease and those things. So I actually want to ask.
Doctor,
Just to add what you are asking, if patient is having cardiovascular disease, established cardiovascular disease, and if we have to use out of two molecules. As of now, we have evidence with select trial, which has been done with semaglutide. With cardiovascular outcome trial with tirzepatide, the results are awaiting. The trial is extended. This is again a very recent information. Trial is extended because there is an active comparator arm with tirzepatide. So therefore, when you have cardiovascular disease with diabetes, obesity, or without diabetes and obesity, you want to use a drug. Probably here semaglutide results are there, so we are going to use that as compared to.
Dr. Tyagi, can I ask you any specific conditions, which cardiovascular conditions, where you would want to do give pharmacotherapy to your patient?
Most common complications that people with diabetes have is cardiovascular disease. So if they have established disease or even subclinical ASCVD or subclinical heart failure, if they have BMI more than 27, try and persuade them to start a GLP-1 analog or a GLP-1 with GIP along with an SGLT2 inhibitor.
Dr. Yadav, would you have any specific indications? What about cardiac failure and see coronary artery disease, and also in the elderly, like what would you consider as indications?
Regarding indication is class 1 indication for chronic coronary syndrome with diabetes, BMI more than 27. So either SGLT2 inhibitor or GLP-1 agonist, class 1 indication. And the patients without diabetes, chronic coronary syndrome, BMI more than 27, it's a class 2 indication. Class 2 set is based on the select trial. So there is only select trial which tested the cardiovascular outcomes. So it has shown the benefit in the reduction of cardiovascular mortality, stroke.
Dr.
Even,
Rakesh Gupta.
even Pioneer trial has shown the benefits in the cardiovascular outcomes.
But no, I think if we see the Pioneer trial, now with GLP-1, which is semaglutide, there are three different trials. One is sustain. Sustain 6 is basically with injectable semaglutide. Pioneer 6 is another trial. Then there is a dedicated trial which is four trial. But we have to understand the differences. Pioneer 6 is done with oral semaglutide. It's not a superiority trial. The design wise, it's a non-inferiority regulatory trial done for the purpose to prove safety of the drug. It's a small event-driven trial. Therefore, it has shown only non-inferiority. In sustain 6, superiority has been shown. But then SOUL is a first trial which is by design made to show superiority of the molecule. Where it is, I was I was a global panel member for SOUL trial from this country. And SOUL for the first time has shown CV superiority trial like that from there. And for the first time, the GLP-1 has also been tested for peripheral artery disease. Although numerically it has shown benefit, statistically it failed to show benefit, but numerically
Right.
even
Okay.
peripheral artery disease has shown
Thank you. Now
benefit.
I'll ask Dr. Rakesh Gupta, coming back to something very basic and practical. Like patients who come to me, and I'm sure to all of us, they have three concerns. One is this safe? Second is, what are the side effects? And third is, how soon am I going to start losing weight? How do you handle these three questions?
Like you handle. So I think we all have our own ways of handling them. But I think it's better to put all points on the table.
Right.
I think there is no point in mincing words. It's not that we get excited and we kind of want to push the drug. I think we must tell them the pros and cons. And I think spending that 5 minutes extra telling them the pros goes a long. So the first meeting with the patient is extremely important. And I think that goes without saying that 5 minutes would go a long way. And the patient kind of get benefiting from it.
What are the safety concerns?
First, I'll tell you what are the most common
Sure.
things practically. First question is, what are the side effects? Now, everybody's social media, sensitization, whatever, we know all that. So I think GI side effects, how soon do we mitigate them, probably first injection, second injection, sensitizing, all those kind of questions will come. And the practical tips which you have mentioned, you eat small meals, or small intervals, etc. So that one point related. How soon? According to a study, within 4 weeks, starts happening, etc. But I won't make them so excited.
The question which actually comes is, कि मुझे ये दवाई कब तक लेनी है?
Yes, that was my next question.
That
See,
is
what happens when I stop taking?
that is the main question. So I think the answer to that question is that I can't predict. Every patient is different, but minimum 3 to 6 months you have to take. Then we will pause for a moment and see where have we achieved, where have we gone, and then we take on further. So there is no finality. It's not an infection. You give antibiotic for 1 week. So I think this is what I would go by.
Practically good thing is that once they lose weight, they don't mind extending the drug therapy for longer time. The initial 3 6 months are very important. If they lose significant weight,
Well,
then
so,
we tell them to
so I will just, as a beriatric surgeon, add a tip here as to what I answer. Now, with our experience with gastric balloon, this is where I'm going to answer. In gastric balloon, also after 1 year, when we remove the balloon, the patient would have a tendency to gain weight. So what we tell them is like, we are putting the train on the track and starting it, and it's for you to maintain. So what with the balloons we were telling them is that in a year's time, you are going to develop a different dietary pattern and a lifestyle pattern. Plus, with the reduction of weight, you will be able to spend that much more time exercising. Like, it's very difficult for somebody to exercise at a very high weight; they get tired very fast. So, once your lifestyle and diet pattern comes to a particular situation, it is for you to maintain it. So, this is not a magic pill; it's not a magic, but yes, it is here to help you. We are here to help you. We are not here to, give, do some magic with which you will be losing weight for the rest of your life. Sorry, you had something to add.
Actually, ये बहुत important question है. हमारी country में तो आपको pocket दे रहे हैं, but in US everything is reimbursed by insurance company. So this question has already come up that how long insurance companies are going to give reimbursement for these drugs, because otherwise the insurance companies are going to become bankrupt. Very recently, a study has been published where what they have done, they have given these drugs for 1 year, right? After 1 year, because already insurance companies have put a cap that we will give only reimbursement for 1 year, only for 2 years. After that, we will not give. After that, what they have done, this is a study now very recently, last month it is published. The patients, after losing X amount of weight, were put on oral anti-obesity drugs like naltrexone, bupropion, or other drugs which are available in US. And surprisingly, at 2 year follow-up, the study which here showed that there is a gain of around 9.5. This is not happening. These oral drugs, which are otherwise milder in their intensity, they tend to maintain that loss of body weight. So this is a very interesting observation, which is very important for our country, that people are spending money out of their pocket, which means let people lose maximum weight in 6 months or 1 year of time, and after that, along with diet and lifestyle, if these cheaper oral drugs in future are available, we can shift the patient to oral.
I don't know if you have read this article, another article, as far as the insurance is concerned. It was talking about how the various other expenses are going to reduce. So, the cardiac stents are going to reduce, the joint replacement is going to reduce. So for the insurance company, they were trying to show the projection how they will actually be, gaining by reduction of bariatric surgery, spine surgery, and
Already in
transplants.
US, they have started putting that.
No, but once you say it is a chronic disease, investment cannot be stopped for a chronic
No, no,
disease.
it is okay, sir. But प्रॉब्लम इज कि पेशेंट्स को आप जब ये दवाई प्रिस्क्राइब करते हो, ऐसा भी नहीं कि वो हमेशा इसको लेने वाला है, वो छोड़ेगा, फिर वेट रीगेन होगा, फिर वो लेगा, और कंपनीज को ये आने वाली है प्रॉब्लम तब तक नहीं.
Dr. Arun, and one question.
I think our
What?
Oh, yeah.
That's a hint.
Recording is cool. I think we'll have some questions from
Yes,
the
because,
Dr. Padar. Yes, Dr.
so
Padar.
since our moderator is a bariatric surgeon, I should ask, what about after bariatric surgery? We have discussed that we have to continue the GLP-1 agonist for almost lifetime, almost. We are not sure after bariatric
So
surgery.
there are situations where we have a partnership and we are talking about giving these medications along with gastric balloons, giving the medication when there is inadequate weight loss. So I've given patients after bariatric surgery where the plateau has become flat. You've given the medicine for about 3 months and they start losing weight. Patients who've got weight regain after bariatric surgery, again, there is a role. So, we have got multiple things in the armamentarium, starting from prevention to, fight this menace of obesity.
Even patients who are not fit for surgery, they can be given pre-surgery,
So
and then
patients
they
not.
become fit for surgery, then they can
So
be
I didn't
taken for
want to get
bariatric
into a
surgery.
surgical discussion. Patients who are very obese, we don't want to do hernia surgery on them, and we want them to lose weight. So then we can put them on the weight loss medication, hernia surgery, joint
Actually,
replacement surgery,
certain
transplant surgery. So we reduce the weight, make them more
So
fit for surgery.
GLP-1 agonist is not in competition with surgery. They can be both utilized
Yes,
together.
everything we have to all
Yes.
jointly fight
With
obesity.
Dr. Prashant, can we, can we just have the last question because such an interesting topic. We'll go on and we'll have enough time during the dinner time to
Okay,
discuss.
last
Because there is another lecture which was missed in the previous session, guest lecture coming from Ahmedabad. We have to do after this session. So please have the last question,
Yeah,
then we'll
I think
discuss
this
in the
question
dinner
for the
time.
panel. The Neuro-Ophthalmic Association of America has observed that non-arthritic inflammatory optic neuritis, the incidence has been significantly increased. That is more than 4 to 6% they have increased. And unfortunately, this is happening. This rise is within 1 year they are getting. First thing. Second thing, it doesn't have any treatment also. There is a sudden loss of the vision. Then how do you face these questions both from the patient as well as from the law if you start the medicine?
This is exactly what Dr. Rakesh Gupta was telling. You have to put the things on the table in the first meeting.
But there's a very specific question. I think if anybody would answer,
Yeah.
in which patients we can actually identify the patients. Please answer.
ये इतना आसान नहीं है because this is available on the social media. So everybody now knows this. Absolutely correct. Warning has been issued. But if you see the prevalence of non-arthritic optic neuropathy, the prevalence is less than 3 to 4 cases per 1 lakh. Now, what are the risk factors? The risk factors for developing this condition is diabetes, hypertension, obesity, and these are also the risk factor for other diseases. Now, whether it's a coincidence, because we have already written a paper, it will get into consideration for publication, the cause and effect relationship between use of GLP and non-arthritic is not clear as of now. You are absolutely right. The numbers are increased, has been observed, probably because of follow-up. So we have to be careful. Second risk factor. Now there is a cup to disc ratio. Whenever you do the fundus examination, there is a cup to disc ratio. Now the cup to disc ratio of Caucasians are less as compared to Asians. And if you have a cup disc ratio of less than 0.2, then probably starting such type of drugs put you at a higher risk. But in Asians, the cup to disc ratio is high and they are not at risk. But these are all in literature. We have to be careful.
Thank you. Thank you very
Just
much.
a last, non-diabetic, no role. This is the final summary, no? I just missed it, the initial part. Non-diabetic, obese, no role of these two medicines.
No. There is a big role of these.
Because I missed the initial part. Yes or no? But that's all.
Yes, there is a role.
There's a role. Non-diabetic, obese.
हाँ
this
हाँ
one-
देना है.
There's a role.
There is. So thank you very much.
Thank you very much, panelists and speakers. And Dr. Modi, if you would like to invite the next speaker.
Yeah, I've been given the task of finishing the previous session's leftover talk by our guest from Ahmedabad, Dr. Abhishek Raj Popat, who is a very well-known interventional cardiologist in the structural heart diseases. He missed his flight, so that's why he was late. So, it's one of the very latest topics in the interventional cardiology structural diseases is the mitra clip. And without wasting time, I'll tell Dr. Abhishek to tell us about the mitra clip step by step.
Thank you very much, and thank you for waiting for me. You discuss about the anti-obesity drug, and you found a candidate on the dais now. So we'll be talking about the mitral edge-to-edge repair. So we know that the pulmonic and aortic is something substantially covered up so far as the structural heart disease segment. We are finding a hell number of patients of tricuspid regurgitation, mitral regurgitation, especially the functional mitral regurgitation is becoming a big challenge. So if I start with the reverse summary, see the mitral regurgitation as these patients are being offered clip in their journey of a heart failure. There is a one subset called degenerative matter regurgitation, where there is a primary therapy for this patient. These two subsets are very, very important in identification and stratifying them. Because if you do TAVI in a cardiogenic shock patient, that patient is for sure going to be good. But if you do a functional MR case, you need to be very, very careful in selecting the patient. So once you start in the program, first you want to see the anatomical suitability. During my talk, I'll keep on talking about the indications and which patients I would not like to touch. If you have a central regurgitation, good coaptation distance, good mitral valve area, not much tenting or not much flail gap, less than 10, less than 10, less than 15 gap or habit, then they are the very best cases to start with. Believe me, if you feel that aortic stenosis TAVI procedure is very challenging, very demanding in terms of arterial access, you are having like a 14 French, 18 French system going inside the body. This is 24 French, but going from the venous side. Very, very less hemodynamic changes happens during the procedure. You have to be very, very, rude to do something wrong on a table where the outcomes are bad on a table. So this is more of a cerebral procedure than a cerebellar procedure. You have knobs for everything. So more and more complex you go when the things are going away from A to P2 segment. A to P2 makes the biggest bulk of the mitral valve. They are least supported by the cords. They are farther away in terms of annulus distance. So most of the time you will end up clipping A to P2. Even if your disease is not an A to P2, in FMR, you start clipping from A to P2 because you create a kind of annuloplasty effect. This is more of technical. So yeah, initial cases, remember central pathology is better. And if you have a good mitral valve area, they are the candidate to start with. If you go step by step, you must have gone through multiple lectures so far. Any transseptal procedure, whether you take a TMVR, you take a L appendage closure, you take a PBMV, the septal puncture is the key. Now, if you observe this slide on my left-hand side, you just see the first slide. You see the shape of the septum. So now there is a big confusion prevailing: superior, inferior, superior posterior, mid fossa posterior, inferior posterior. And this is located in an oblique manner. So unless you are at the mid fossa or lower, you cannot go away. You cannot go posterior. And this is a slide which says you that if you go more posterior, you are going more away from the mitral valve, and that's how you are going to gain the height for your device manipulation. So what we call the parent view of clipping is a bicommissural view, where the view is passing through the commissure. Mitral valve is a smiley type of commissural pattern. So you are getting a P3, A2, and P1 in this fashion. And this is where we locate from where the jet is coming. This is where we know that, okay, this is the place we want to grasp. You should be able to see two papillary muscles. Next important view is the LVOT outflow view, where you are seeing the anterior and posterior leaflets or a scallop, and that's where you grip. We use a multi-dimension or X-plane very commonly. Then in your eco learning, how to create a 3D end face, you put your aorta in a way that either it is at 12 o'clock, or you can see your mitral valve smiley in a symmetrical fashion. Transgastric is only for knowing the mitral area. This procedure is so far TE guided. In a tricuspid clips, we are using the 4D eyes and everything for additional thing, but the TE remains continuously, and that's the very reason that these patients are in general anesthesia. What you need in access is a venous access and an arterial line for a pressure monitoring. Heparinization standard, just like angioplasty, TAVI, 100 units per kg, keep your ACD more than 250. And yeah, GA hai, so we have to keep the patient in the Foley's catheterization. Now we use this ground plate. Basically, the purpose is, you're keeping your system above the heart level. So the air embolism chances go down. You keep it like 80, 85 centimeter away from angle of Lewis. Access, books will say go for ultrasound, but we can have a good venous access without that also. That's not a big challenge. Go to transeptal. So now we need to be having a height because the system will flex. So you need to be like 4 centimeter away from the coaptation site. In the functional MR, your coaptation is happening in the ventricle. In a degenerative MR, your coaptation happening in the atria. So the puncture should be like 3.5 is okay for FMR case. If you are doing a DMR case, try to stay above 4 centimeter from the mitral valve. Different sheets, which we are not using so far. We are okay with the Moulins. But yeah, depending upon the size of the atria, you can select whether you want to go SL0, SL1, BRK, BRK1, BRK2. Transeptal location, if you see eco guiding person, We'll show you the superior, inferior location by bicable view. Good bicable view is necessary. Most of the time, we see that you are able to see the SVC. You are not seeing the part of IVC, and then you don't see the thin part of the septum. And other important thing is you see the anterior posterior in a 45-degree view. Again, try to see the thin part of the septum. And once you have your needle against, you will have a tenting. Don't try to locate the shaft of the needle. Look at the tenting. Tenting is the only surest sign that you are against the septum. Don't hit unless you see a tenting. Otherwise, you are going to create a stitch and patient will end up with a pericardial effusion. This is how the tenting looks in a different view, short axis, bicable. And this is the way we measure the height from the tenting side. If you can see the tip of the both mitral valve moving freely, that means you are not off axis. If your tenting is in a different plane and your highest mitral valve expression is a different plane, then you are entering the LA in oblique fashion. So at the site of tenting, using a vertical distance to the mitral valve coaptation site. So as I said, puncture should be 4, 4.5 for DMR, and for FMR it should be 3.5 to 4. We have done cases with 3 also, but then you have a less chances of manipulating the clips. So after puncture, you get your system in. So the new generation systems are having a pressure port side. If you don't have a pressure port side, then you put a 2 wires. On one wire, you get your delivery system, and another one you put a picture into the LA for continuous LA pressure monitoring. So when you get this MyVal MGC, the guide system, you go in. The system has a natural curve at the top. So while entering, you need to rotate the minus knob to straighten it. But once you are entering going across the septum, you have to just let it be in a natural position, because that's how it goes easily, because otherwise it will go right up to the LA roof. So you make it neutral position. And then now, once you remove the dilator, you have to check one thing, that how deep you are inside, how deep your MGC guide is inside there. So 3 centimeter is really good, but don't go less than 2 centimeter in there. Because then you are too much moving out, and the chance that you pop out, and the patient is already happening. And at the same side, you see the location, that how you are aligned against the mitral valve. Because if you are not aligned, you will end up doing a lot of maneuvers. If you enter the LV in a tilted fashion, you have a toe tension inside, your gripping will become difficult. Once you have kept your guide, you do your air pressure measurement in the V way we want to see. Then you put this rubber and a kind of this bracket feet and this mat, so that it remains higher, it remains straight and above the heart level. The optimal trajectory is, again, I said, you should be able to see the canting and your highest expression of mitral valve into the same view. You should not be requiring to change your angulation or maybe rotation of the probe to see the one thing, and the sequence not in the simultaneous fashion. Once you get inside, you get it clipped in. So in my personal practice, I get my catheter like 3-4 centimeters inside, make my clip in the initial part of the entry of the clip. I do it by unsheathing the guide catheter. Once you unsheath that, this is a little bit. Once you unsheath that, you create this kind of a sandwich where the two neural system markers are in the middle across this thick guide marker. So this is called, we call sandwiching. Some people call it like straddling. So the purpose is that because that's the point from where your clip is going to flex. If that is inside, if it is going to flex or going to have a medial movement while you are inside the system, and your clip will not respond in a one-to-one fashion. So when you are doing a clip procedure, you should always have your eye on this sandwich, so that you are not missing that position. Then you rotate the M knob. I think the lecture would have been much more bulkier. So you rotate the knob and the clip starts flexing. While you're doing it, make sure that you don't touch the nearby structure, LA root, comedian bridge, or LA appendage. Echocardiography has a bigger role to play. The captain stays on an echo probe. It's not the captain who is flexing the knob. Knob flexing is not a very big task. You should be able to do an echo by yourself, or if not, then you should be able to comprehend the information from that. So once you get your position, keep your valve in a bicom view and an LVOT view at the level of the mitral regurgitation site. You should be ideally, splitting the jet. So first of all, what we do, we open the clip up to 60 to 120 degree inside the LA. We check the orientation. Again, after that, you see the 3D and plus view. The clip is not perpendicular to your side. So now, the important is not 12 o'clock, 6 o'clock position. Because if you're doing A1, P1, it comes up, it will be like 1 and 7. If you're doing A3, P3, it will be like 11 and 5. So the purpose is that your arm should be perpendicular to both to the mitral valve coefficient side, and it should be splitting the jet or should be in the dominant part of the jet in both the views. And these two views are 90 degrees to each other. So when you're doing an X plane, you should not be seeing any part of the clip in the micro view. You should be seeing that both arms in equal sizes in the LVOT. And you should be perpendicular to your smiley, the orifice in the 3D and pass view. Once you do that, just dive in. Diving is always at the 60 degree. You go inside, you just open the clip further. Usually we start with we clip around 120, 130 degrees. But if you have a very short PML, if the perfume gap is too much, then you might like to open it 180 degrees. Bring your clip up, the scallop, you sit on that. If you're okay with the adequate amount of the deep plate inside, you put your grasper down, then you can you close the clip to 60 degrees. You do your assessment in the 60-degree view. Again, you are checking alignment because once you're diving in, it can rotate or can get twisted. This is how you pull the clip up, and you see the both the weakness AML and TML are inside clip arms, and then you drop the graspers, and then you do your assessment at 60 degrees. If you are happy, you release the clip. After release, you check a couple of things, mainly the mitral valve gradient, your mitral regurgitation. If you are having a big jet or maybe a big swell gap, the first clip has to be kept medial. If you are expecting a two clip, and you put your one clip medially, because once you take a second clip, you go from lateral to medial side. If your clip is already lateral, the second clip can actually can hit, and it's not that clip. Sometimes if you feel that the liquids are moving too much, you can create an apnea or maybe a sometimes low tidal volume situation just to let your graph to be better. I just want to take my time. Always pre and post procedure after clipping, you check the pulmonary vein flow, whether you have created forward flow or not, and for reversal. Again, check the LF pressure reduction. Very important in a DMR case. You don't see much dramatic changes in FMR case, but at least see that your mean pressures are coming down. Gradient assessment is important for end of the procedure as well as for the considering the second clip. If you are reaching the barrier of 5 millimeter of mercury, you should have a detailed discussion whether the second clip should be put right now or not. But at the same time, the residual MR can have a flow related gradients also. So whenever in doubt, put the second clip, be careful in the release. You have seen adequate number of occasions where you put the second clip, MR goes down, and gradient actually in stereo goes down because they were flow related gradients, they were not because of the mitral valve disease gradient. Deploy the clip, retrieve your system, complete your assessment. If you are happy, you move your guide, the procedure is done. Only thing about the post-procedure care I would like to tell is that in a TAVI case, CCS patient is going to do fine. But in a clip case, especially the FMR cases, you're going to have what is very known in tactical surgeons afterload mismatch. The heart was able to get empty from both the directions. Now it goes in anteriorly, and sometimes the sick heart cannot handle that. Many patients require intubation or maybe elective balloon pump, and post-procedurally also they might require them. So initial program when you are starting, try to have kind of a protocol of overnight ventilation and doing it for every 3-4 hours. Because usually this happens most of the time we can see on table that how much it has gone down. But up to 6 hours there are high chances, but yeah, it can start appearing in 24 hours as well. So the post-op care will be very, very different in a clip situation versus wall replacement of TAVI situation. So assessment, the gradient, residual regurgitation, amount of tissue bridge stability, because you have to see that you have not done a single leaflet attachment, you see the stability of the clip. Then electric ventilation, and you use inodilator if the patient gets upload mismatch. Because if you use NORAD or DOPA, the heart has to again, the heart has to again work against the resistance. Usually you start with middle mount for this. This is a detail of the post-op and tactics which can be skipped. Thank you very much for your patience and time.
Thank you very much, Dr. Abhishek. Um, what Dr. Abhishek didn't tell or probably hesitated to tell is that metro kits are now being made in India. We Make in India program, which is we are very proud that these kind of very sophisticated devices, which were used to be imported only, made in India. So that's one thing. And second thing, what you told is very, very important that after you reduce MR in a failing heart, the post-op management or post-procedure management is extremely important. Whatever you want to choose on the option. So you are reducing MR, you are increasing afterload. So patients can land up into accelerated heart failure if you don't manage the thing.
So usually the clip patients don't die on table. They die during the post-op situation because the heart is not able to handle the excess after, which was not the only option before the clip.
Thank you very much, Dr.
Thank you, sir.
So,
Yeah, so before we close the session, it's very good to see like 15 minutes past 8 o'clock. We have so many people who are interested and who are waiting without food and dinner to listen to you and the interesting topics before your talk. Just one thing, one that Dr. Modi said, we are very proud that Mary has come up with this indigenous group, and it has really brought down the concept that indigenous has brought down the cost. And very good to have people like you to look us out. And we are very proud, both me and Dr. Modi, that we have seen Alma from the three done our DM, and we are very proud of you.
We had a very good guide and mentor to you follow.
So I'm happy. I know you have to do a case and we requested you to join this. And what is the learning curve for an average international cardiologist to exercise or start doing microplates on its own?
I think it's going to be longer and a little bit different because if you want to learn intervention, you have 100 people or 1,000 people in India who can teach you how to do intervention. But you cannot do a successful clip program unless you can do echo or you can understand the terminologies being used or image acquisition is required by you. Because your echocardiographer might be doing some mistake and if you cannot figure it out, that's where you're going to suffer. So if you want to have a successful clip program, starting from patient selection, everything is going to be. I really request those who are interested in the young generation, spare your time. There are a couple of initiatives like and there are the boot camps being organized in Europe as of now, but yeah, we expect that in the future in India also will visit the organizations and institutes will be dedicatedly teaching this PER therapy related approach. Believe me, it took 6 months for us to create those views and completely do an assessment. Well, I am dedicatedly doing only structural. I am not in the coronary area. So it's going to be a little bit learning curve. Yeah, companies can give you enough support that you feel that okay, everything went well, there's no problem. The procedure was not hemodynamically demanding. But to become independent in knobs in clip, you should be able to coordinate more. I'm not able to see the capillary muscles. That's very important for them to start focusing. I think this should start percolating from our university itself. That's where the interest are putting in intervention.
Yeah, and I think imaging, and especially echo and other intravascular imaging, is now to become, again, it has to be an integral part of intervention training. I mean, we bifurcate into invasive and non-invasive cardiology. You have to go back if you are an intervention cardiologist and a structural specialist or a vascular specialist. You need to do training and retraining to imaging and especially echoes and understanding echoes and you pay close to damage to these are working using the mind. Thank you very much. And we have to change 3 flights for Dr. So busy. I mean, I think he's probably done 2 cases today. He's here. Going back tomorrow again.
One for tomorrow, but I have to see the picture.
Thank you very much
Thank you,
for
sir.
making it.
Right?